en vivo.
Ok. Ah, ok, perfecto. Disculpa, primero vas con la introducción y después DAC. De acuerdo. Está perfecto.
Now we are in Facebook Live.
Perfecto. Yo te decía que pegaras el link de acceso directo. Ah, pero también puede ser el link de la inscripción, ¿cierto?
Ok,
Cuando
se
tú
están
quieras.
uniendo ya nuestros asistentes. Vamos
Cuando tú quieras, Diana.
cerca de 400. Vamos a comenzar.
Dianita, ¿puedo decirte algo?
Sí.
Explicarle a la audiencia que usen el chat de preguntas y respuestas
Sí,
solo para preguntas y
tranqui.
después. Ok.
Un minuto más y comenzamos.
Ugasi puede entrar.
Sí. Creo que está todo bien. Bueno, vamos a dar inicio a nuestro primer meeting internacional by Zoom. Hola amigos de habla hispana, soy Diana Romero de Colombia. Hello friends English spoken. I'm Diana Romero from Colombia. Voy a dar algunas instrucciones del canal de traducción, primero en inglés y luego en español. First, I would like to explain about the simultaneous translation. Below in your screen, you can see our icons as interpretación. Please click on and you will be able to choose English or Spanish voice from our translators. If you like to hear in Spanish, push Español. If you like to hear in English, push Inglés. Abajo en sus pantallas encuentran el icono del mundo. Hacen clic y se despliega las opciones de los idiomas en los cuales desean escuchar el seminario. Si no desean escuchar la traducción, escogen la opción de apagar. I would like to introduce Claudia and Silvana, the interpreters who are going to make my life much easier. Les presento a Claudia y a Silvana, las traductoras que harán mi vida muchísimo más fácil. Gracias, equipo Clínica Chayo. Día a día estamos trabajando por nuestros niños con enfermedades de vía aérea. Gracias por el apoyo en la organización del evento. Como es un evento de modalidad webinar, lamentablemente, Ustedes no podrán encender sus cámaras ni sus micrófonos durante las conferencias. Así que les voy a dar algunas recomendaciones. Primero, las preguntas. Abajo en la pantalla, ustedes ven un icono de preguntas y respuestas. Este canal será usado para las preguntas hacia los conferencistas. Será el único canal que se usará para acceder a los conferencistas. Realizaremos algunas encuestas durante el webinar. Están invitados a ser partícipes de ellas. Tendremos un descanso de 10 minutos. Y al final del evento habilitaremos el video y el micrófono de algunos asistentes para comentarios y preguntas adicionales. Recuerden, hay dos canales de comunicación, uno para preguntas y respuestas y el otro para el chat. Por favor, las preguntas al canal de preguntas. Y si tienen alguna dificultad, favor enviar un mensaje escrito. Bienvenidos. Somos 54 países conectados alrededor del mundo en este webinar internacional de vía aérea pediátrica. Bienvenidos amigos de Indonesia, Malasia, Taiwán, India, Uzbekistán, Qatar, Bahrein, Arabia Saudita, Jordania, Palestina, Pakistán, Israel, Irán, Egipto, Sudán, Kenia, Sudáfrica, Rusia, Alemania, Emiratos Árabes, España, Francia, Turquía, Grecia, Holanda, Inglaterra, Irlanda, Italia, Portugal, Suiza, Suecia, Canadá, Estados Unidos, México, Curazao, Costa Rica, Guatemala, Nicaragua, Honduras, Panamá, Paraguay, Uruguay, Perú, Argentina, Brasil, Chile, República Dominicana, Venezuela, Ecuador, Colombia. Bienvenidos amigos de Filipinas, Reino Unido, Bolivia, Trinidad y Tobago, quienes se han unido a nuestro evento en las últimas horas. Tengo el gusto de presentarles un gran panel de conferencistas. Bienvenido, doctor Russell Jennings, Reza Rabar desde Boston, Douglas Seidel de Stanford, Mike Rutter, Catherine Hart, Alessandro de Alarcón de Cincinnati, Diego Preciado de Washington,
Marilena Trozzi de Roma, Italia. Michele Torre de Génova, Italia. Jaime Penchina de México. Gastón Beliá y Patricio Beliá de Buenos Aires, Argentina. Álvaro Pacheco de Chile. Diana Romero de Colombia.
y Patricio Varela de Chile.
También nos acompaña Hugo Rodríguez de Argentina y Michele Ugasi de Ecuador.
Ahora te doy la palabra, Pato. ¿Tienes algún comentario?
Gracias por la introducción, Diana. Creo que podemos comenzar.
Doy la bienvenida a Douglas Seidel, otorrino de Stanford, quien despertó nuestro interés hace un tiempo respecto a la terapia sistémica de la papilomatosis recurrente. Gracias, Douglas, por acompañarnos. Tienes la palabra.
Thank you. I'm going to share my screen. It is an honor to be here. Obviously, I'd like to thank Patricio and Diana for putting together such an amazing program. Are you all able to see my screen?
Sure.
Sí, estamos
Okay.
bien.
Well, you know, this project is a project that surrounds the use of systemic or intravenous Avastin, or bevacizumab, for the treatment of recurrent respiratory papillomatosis, which many of us face on a daily, weekly, or monthly basis in our institutions. I'm from Stanford, and fortunately in California and in the United States over the last several decades, we've seen a decline in papilloma, but it also means that some of the papilloma that we are seeing can be quite severe. And as you know, papillomatosis is quite common around the world, and no matter where you are, it seems to be quite variable in its presentation, both between individuals and also within the same individual. It can have a very erratic course. We know that the mainstay for treatment is surgery, but there are also many adjunct therapies that can be used, and there is no cure for this disease. Bevacizumab, or Avastin, is an antibody that was designed, a recombinant antibody, designed to actually bind the growth factor for vascular endothelial growth factor molecule, and it inhibits the molecule's interaction with that receptor. It was initially approved for systemic metastatic carcinomas like renal cell, colorectal, and lung cancer, but it has also been used locally for non-neoplastic diseases, angiogenesis in patients with retinopathy, and also patients with hereditary hemorrhagic telangiectasias. I became interested in this in a large part due to my mentors, Dr. Alessandro D'Alarcon in Cincinnati, and through his work with Steve Zeitels. They demonstrated that you actually can use this medication locally by injecting the lesion and having a significant response in a subset of patients. Nevertheless, the therapy does not work for everybody, and while you may see a dramatic response in some, it is not, by no means a cure. Over 10 years ago, people had started using this also systemically in the treatment of severe papillomatosis, and over the last decade, a sprinkling of papers has come out, both from Germany as well as the CHOP group, and also some work that has been done by Dr. Preciado's group, and showing that patients with very severe disease, as you can see on the right, tracheal disease, can have a dramatic response. And we saw this early on at Stanford in some of the patients that we had who've had very severe tracheal disease. The problem with this medication is that we still have many questions with regard to how to use it. We don't know who the best patients are who should be receiving it, why some hospitals allow the treatment and some do not allow it because it is off-label use. We don't know how long to treat, what to do if the papilloma returns, and we don't know what locations of papilloma this actually helps. And so our goal with all of this was to really try and find a consensus amongst our the providers who are using this, experts in this field, with regard to the appropriate use of papilloma, intravenous Avastin for the treatment of papilloma rather than just metastatic cancers. So we sought out to try and achieve expert consensus, and we've done this using the Delphi method, which is something that's over 60 years old. It's a method that allows for experts without much objective data to come together and actually provide information that they think is important, and then anonymously work through that information to come to a consensus. What we do is we actually provide characteristics or variables that the group thinks is important. We then send them out to the group as a whole and we rank them. We provide feedback to the group, and then through an iterative series, we are re-ranking those criteria until we actually come to a consensus with regard to which criteria are important and which are not. And while it seems complicated, it is actually quite simple, but it is very time consuming and it requires a good working group. The way that we achieve consensus or near consensus is all based on a priori criteria. I don't need to go through this here, but it basically, we look at the responses and try and determine whether or not the vast majority of the group believes that the response is worthwhile to include or to exclude. The first step for us was to identify the experts. Trying to find people who have used intravenous Avastin for the treatment of recurrent respiratory papillomatosis was no easy task. We used communications applications like WhatsApp. We used email networks, word of mouth, and then we used social media and the RRP task force. We identified over 250 people who had good experience with the use of Avastin, and we came down to a final working group, which ultimately was determined by the people who were responding to over 50% of the surveys. The working group consisted of over 70 participants from 56 institutions and 12 countries. And we were otolaryngologists, pediatric surgeons, hematologists and oncologists, infectious diseases specialists, and we have providers from family medicine and with epidemiology background training. Now, there are 4 primary categories that we wanted to look at, but the first project, which actually took over a year to complete, really just looked at the patient selection guidelines. What patients should we be offering this medication to, and what does their institution look like? And I'll go through some of the responses that we have here. And again, this is just a very broad overview. There is too much detail to cover in 5 to 10 minutes here. Initially, we came back with actually what was closer to 1,000 responses of patient selection criteria that were proposed by the group. I had to translate them into the English language. I had to remove duplicates. We kind of collated them and we put them into groups. And the groups we found that most people in the working group felt important were these 5 domains, such as the characteristics of the patient, what disease characteristics did the patient actually have that would suggest bevacizumab or Avastin to be of use, what were the characteristics of the actual treatment center where they were getting treatment, what did they have done before we actually decide to use intravenous Avastin, and then what workup do they need to have before we feel like we can safely apply this. We had a total of 184 items that ultimately required rating, and 4 forced choice items. And by that, the forced choice are just yes or no questions. After we rounded through 4 surveys, we came to consensus on 56 items by criteria, and we came to near consensus on 14, and we were able to eliminate 114. And the idea is actually to bring the consensus number down as low as reasonably possible. So when we're looking just at these patient characteristics, there are, again, several, and I'm not giving you the exhaustive list, but to kind of summarize some of the important ones, the patients who we felt would really support the use of bevacizumab would be patients who had a severe reduction in their quality of life due to the papilloma or limited alternative care options. They didn't have other options for treatment. Patients would need to adhere to the treatment, which sounds very reasonable. We should not be pregnant or going to get pregnant during the use. And interestingly, and I think this is important, all patients were felt to be considered for treatment regardless of the age at the time of papilloma diagnosis and regardless of the age at treatment. Therefore, patients should not be excluded if they're very young and should not be excluded if they're very old. With regard to the disease, the summary for the disease findings is as we would expect. Patients who have disease that's very hard to reach surgically, patients who have disease that's breaching the larynx, patients who have disease that is very severe or recurrent when it comes to airway obstruction. So patients who are constantly having airway obstructive symptoms and may benefit from having this systemic therapy. The treatment center was also something that we looked at and felt to be very important. The consensus group felt that the treatment center should have subspecialist providers actually caring for the patients through all of the subspecialties who may be involved, including radiologists, pathologists, otolaryngologists, and pulmonologists for those patients who had pulmonary disease. If children are the patients, we felt that pediatric providers should be leading the way, and the center should have admission capabilities and the ability to transfuse the patients if they were to have complications, which again seems self-explanatory. With regard to the prior workup, we felt that the patients should have a very comprehensive serologic workup, but I should point out that just because we felt that the patients should have all of this lab work done, with the exception of the CBC, the working group did not feel that the workup had to provide normal lab values. You could have some abnormalities in your lab values, but you should at least have a baseline labs obtained ahead of time. We wanted the oncology group to actually be guiding the lab evaluation and management. And also the patients should not have had any recent surgery or have any major surgery upcoming within the next month. We also felt that an endoscopic evaluation with biopsy should be performed and an oncology evaluation prior to undergoing intravenous Avastin for papilloma should also be performed. The idea behind this, again, the paper is much more extensive with regard to the outcomes, and this should be coming out soon, is, we want to provide a framework for people who are already using IV Avastin so that they can structure their patient selection and also help their center design a good mechanism to treat these patients. For providers who are not yet using Avastin and maybe their center is not supportive of the Avastin use, we wanted to provide a statement that could allow for some form of a framework or strategy for the centers to begin offering this treatment to their patients. And then lastly, there are several ongoing trials out there for RRP protocols for adjuvant therapy. And we wanted at least a basic platform for bevacizumab use with other RRP protocols. So without taking up much more time, I'm happy to answer any questions about this quite large project. And I'd also, of course, like to thank the people who have been so instrumental in collaborating with me, Dr. Craig Durkay, Simon Best, Karen Zur, Karthik Balakrishnan, and our own research support, Julia Buckingham here at Stanford. And of course, Dr. Alessandro D'Alarcon for being a lifelong mentor and spurring my interest in treating this disease many years ago. My email is here and I'd be happy to discuss any of this via email later if that is easier for the group.
Hi, Doug. Excelente.
Un momento. Gracias, sí. Un momento. Sí. Douglas, gracias por compartir con nosotros el excelente trabajo, un gran aporte para nuestra comunidad. Me pareció increíble ese trabajo realizado. Tengo el gusto de presentarles al doctor Hugo Rodríguez de Buenos Aires, Argentina, para que nos comente algunas inquietudes. Hugo, bienvenido.
Muchas gracias, Diana. Excelente la iniciativa, excelente presentación, Doug. Felicitaciones por el excelente trabajo con el método Delphi. Realmente es un trabajo arduo. Nosotros en nuestro hospital tenemos 9 pacientes tratados con bevacizumab sistémico, todos con una evolución bastante favorable para lo que es la papilomatosis, que sabemos que es absolutamente impredecible. Yo quería hacerte algún tipo de pregunta, Doug. Por ejemplo, ¿cuál es la experiencia que tenés con respecto al bevacizumab y la enfermedad pulmonar?
So, this again is like all papilloma, seems to be quite variable. I have known at least 2 patients who have severe pulmonary and tracheal disease. And while the tracheal disease was managed very effectively with the bevacizumab, the pulmonary disease also progressed. And in one patient, when we actually stopped the Avastin therapy so that the patient could participate in a large trial for another medication, the pulmonary disease actually came back with a vengeance, and it nearly cost the patient his life. And so, unfortunately, while the treatment is very effective in this subset of patients in managing tracheal disease, and again, in some patients, pulmonary disease, in those patients where pulmonary disease is not managed well, it really reminds us that, like many other adjuvant therapies, systemic bevacizumab is an excellent therapy, but it is by no means the cure.
Perfecto. Y al principio uno utilizaba el bevacizumab sistémico para enfermedades laringias o traqueales graves. ¿Tu idea es seguir con esas mismas indicaciones o empezar a dar indicaciones un poquito más en otros pacientes que no están tan graves?
Based on our, excellent question, and thank you, Hugo. Based on our experience with the working group, I actually have much more comfort now in expanding our indications for bevacizumab use. There are a subset of patients who have very localized disease, but obstructive disease at the level of the glottis. And they're much earlier in their history with regard to the duration of time that they've had papilloma. And we have a subset of about 5 patients now who are being evaluated for intravenous Avastin use. All of them are children. All of them are under 10 years of age. All of them have localized glottic disease, and we plan to at least infuse a subset of those patients. There are also reports anecdotally of patients who have been treated with intravenous Avastin very early in their course of disease, after maybe 1 or even 2 treatments in the operating room, and have had a dramatic response without recurrence. So I think we do need to start considering the use of intravenous bevacizumab for patients with less severe disease earlier in the treatment course.
Perfecto. Y otra pregunta más. ¿Hay alguna edad límite inferior? O sea, ¿cuáles son los chicos más pequeños que han tratado? Y otra duda que tenemos es ¿hasta cuándo seguimos el tratamiento? Una vez que se terminan los ciclos de bevacizumab sistémico, ¿hasta cuándo seguimos? ¿Cuánto es la periodicidad? Porque hemos visto que cuando disminuimos el tratamiento empiezan con mayor sintomatología. Perfecto.
Excellent. So, you know, the youngest patient that I personally have treated is 8 years of age, and he would have been an excellent candidate for earlier therapy. Based on the working group response, we should not consider age as being a criteria which would eliminate the patient or preclude the patient from therapy. So I think the young age does not, or old age should not preclude therapy. I think we need to look at the general health of the patient and look at each patient individually with regard to their risk factors and disease burden. The initial therapy, we start out on a Q3 week or every 3 week interval, and we will run this for 3 or 4 cycles before spreading that out. We have spread patients out and managed them up until about 4 to 6 month intervals. Every patient that I have been personally involved with who we have spread the infusion interval beyond 6 months has had a recurrence of disease that requires surgical intervention. There are several patients who are receiving intravenous bevacizumab every 3 to 6 months who we are following clinically and do not have any requirement for operative debridement. I know anecdotally of patients who have come off of the bevacizumab therapy without any recurrence to date, but the majority of patients that I have experienced personally have not been completely cleared of their disease and continue to receive infusions. Nevertheless, in the pediatric population, the parents are much more willing to have the child undergo an infusion every 4 to 6 months than a operative debulking every 6 weeks. And so we feel that the benefit is really there. If the papilloma does come back, reinitiating the infusions or increasing the frequency of infusions does again seem to knock the papilloma back, and it does not seem to progress more rapidly after the cessation.
Bueno, muchas gracias, Doc. Creo que Diana, estamos en tiempo.
Gracias, Hugo. Estamos en tiempo. Vamos a continuar porque está.
Las preguntas van a quedar para el final del chat, probablemente al final del evento, las que han escrito en el canal de preguntas.
Bueno, siempre es un honor tener a Mike entre nosotros. Sin duda nos va a deleitar con su conferencia sobre su perspectiva del tratamiento endoscópico de lesiones de vía aérea.
Good morning. I'm going to share my screen shortly, and I appreciate that we're running a little behind time, so I'll try to not be unduly verbose. And let's go to that one. Hopefully you can see this. Let's find out. Excellent.
Perfect.
That looks good. And we're going to go to that version. Perfect. Okay, so I've been asked to talk about endoscopic treatment and pediatric airway innovations, which is quite a fun topic. And in the interests of time, I'm going to blow through the disclosure slide. Most of the people in the audience have seen some version of this in the past. I work with a lot of people. Brief advert, if you're not already using the mobile Airway card, which is free, you should download it. And so I'm not going to talk about AP splits because Catherine Hart, who's been detained in the operating room, has handed over to Sandro de Alarcon. He'll be talking about that very shortly, amongst a few other things. I'm not going to talk about clefts. Razor's got that. I'm not going to talk about vocal cord surgery because lots of people are talking on that. And I'm not going to talk about pouches, keels, coin removal, because there's just not enough time. So I am going to talk about subglottic pincushion cautery. I'm going to talk about some aspects of augmented balloon dilation. I'm going to talk about TEF repair with voice gel injection. If there is time, I will touch on the Swiss roll pharyngeal stent. So firstly, atypical croup. And croup may be due to an anatomical problem, like subglottic stenosis, but more commonly is due to a physiological problem. Your subglottic mucosa swells very easily. And typically, this is something that is ultimately self-limiting. Very occasionally, you will have an atypical croup where you want to do something about it. And if you have a child who's older than they should be, or they have crescendo croup or very severe croup, then it may be worth considering an intervention. And the intervention that I've started to do is a subglottic cautery, and this is working on the concept that scar does not swell. And so if you can deliberately make a series of very small scars in the subglottis, the normal area around the scars can swell, but the rest of the subglottis is pinned down to the cricoid perichondrium and will greatly reduce symptoms, if not eliminate them. And the key here is to do non-contiguous burns, as you can see here. So this is using a Bugbee cautery and just pinholing the subglottis, a series of little burns, so those areas cannot swell, and the areas between can swell, but not nearly as much because they're held down. And so far, we've actually just published a paper on this, and the results are pretty good. So let's move forward. Yeah, Doug, I can see you laughing in the background. I fully agree that I am not one of the world's great geniuses in terms of evidence-based medicine. So the statistics on that, they seem to work. So let's move into balloon dilation. And when is it beneficial to do more than just dilate? And so an augmented dilation. And so this usually means that you're dealing with a thicker scar, an active scar, or an older scar. And we're augmenting with steroid injection and scar division. And so typically I'm using Kenalog put through an orotracheal injector. And this is a 30 gauge needle. This will allow you to inject about 0.8 mils from a 1 mil syringe. And then I divide the scar tissue. I quite like the Blitzer knife because the blade is always sharp, it's disposable. And I'm going to present two cases relatively fast. This is the time of COVID. And both of these cases have come in over the last couple of months. They're both 12. They both had endotracheal cuff injuries. They both had a severe tracheal stenosis. They presented within a few weeks of each other. They both got dilated. One is a success and one is a failure. And what can we learn from this? So I'm going to present case 2 first. She presented in early April and was intubated a couple of times a year ago for a fractured femur and then later for a metalware removal. And she's very exercise limited. Her airway size with a 3.0 endotracheal tube, had a 14mm balloon, and her stenosis was established. It's been over a year since she was intubated, but pretty firm. And her progression, so day 0 you just saw, on the left is day 10, on the right is day 20, and she sized initially with a 3.0, then a 6.5, pre-dilation 6.5, 7, just using 14mm balloons. And we did augment, as you can see on day 10, where we're injecting some Kenalog in the scar, and then we're going to divide some scar bands, or the worst of the scar bands, with a blitzer blade. And again, a tool is a tool. You could choose to do this with a laser if you wished. And again, with a blitzer blade, I typically put it in through the scar upside down, then I spin it and cut down into the lumen. It's a nice technique. I'll show you this again here. I go in with the point backwards, spin it round, and then I can pull into the lumen. It's an easier way of actually cutting through scar tissue than starting medially and working laterally. So I start laterally and I work medially, and then we balloon dilate. So steroid injection, scar division, balloon dilation. And this is her on day 34. And she takes a 7.0 endotracheal tube. She's asymptomatic, and we're going to see her back in another couple of months, and I think she'll be fine. Meanwhile, this boy, we failed. So he was intubated for only 2 days in a diabetic ketoacidotic coma. He's extremely limited. I did not size his airway because he wasn't stable enough. And as you can see here, this is a 14mm uninflated balloon, and I am struggling to get it through that stenosis. As you can see here, that's a very small airway in a boy without a tracheotomy. I had to really push to get an uninflated balloon through there. 14mm balloon, inflated it, not for a very long period, just to give us an airway. And we're now in control, and we can better evaluate the airway, and we can see that this is a long, inflamed stenosis from a cuff injury in a boy who didn't know he had diabetes till he presented comatose. And so what did we do with him? And again, you can see day 7, he looked pretty good. Day 41, he's re-stenosing. Day 90 is the day we gave up and did a slide tracheoplasty. And so initially, I don't know, I could have got a 2.5 endotracheal tube in him. We were making some progress, but if you look here, the red, we lost at this point. And that was a 3-week gap because of COVID. We couldn't quite do what we had hoped to do. And it ended up that he just kept re-stenosing. And oops. And so this is him yesterday. We did a slide 8 days ago. This is him yesterday. It's wide open. I didn't size it, but I know a 7.0 would fit through there. And I think he's now going to be fine. So what do we learn, if anything? So 1, diabetics do worse. And this is not the only time I've seen this happen. 2, long segment stenosis is more difficult to manage. 3, if you're going to dilate, I think you need to do a short burst of rapid cycle dilations, 7 to 10 days. And 4, when is the best time to augment a balloon dilation, doing the steroid injection and the scar division? I tend to do it on the 2nd visit in this little run of dilations. But can I prove it? No, of course I can't. This is purely experience-based. And obviously, we're trying to work with rabbit models, or Catherine Hart and Sandro Dialacon are, to try and answer some of these questions. So now I'm going to move forward on a modification of the endoscopic tracheoesophageal fistula repair that quite a few of us are now doing. And so again, the concept is if you have a long, skinny tract, you want to demucosalize the tract, you want to have one raw surface up against another raw surface, you want to prevent air or saliva moving through the tract as its scars closed. And so where possible, we're using a voice gel to enhance the closure. And whether it's Radiesse or whether it's Prolarin, it doesn't matter. You just need a temporary spacer. And so this is a girl born with a type C and turns out to have a recurrence. So we're suspicious. So one of the ways of checking is to put a cuffed tube in the esophagus, give a positive pressure breath, and see if there's any air leaking out through the trachea. So that's where we're suspicious, positive pressure breath, and are you going to see bubbles? So a sustained 30 centimeter water pressure breath, and yes, that's clearly a tracheoesophageal fistula, not a pouch. And so this is when we're doing the repair, so we're going to use a bug bee cautery, and again, you could use trichloroacetic acid. And we're going to deepithelialize the tract, coming proximally almost into normal trachea. And then this is the, back at this point, Radiesse gel injection. And this is technically fiddly. This is difficult to do. And so what you're trying to do is on one surface, you're trying to, in this case on the back wall, you're putting a blob of Radiesse, which will only last a few weeks, but it's going to compress your deepithelialized back wall of the tract up against the deepithelialized front wall of the tract. And this is a month later. And again, we've got a complete closure. The Radiesse is mainly gone at this point in time. You can barely see where the tract was. And so this has converted a operation where usually I would warn parents, you might have to try this 2 or 3 times, to if you can do this successfully, you're far more likely to be able to have success with a single attempt. So now we're going to go through pharyngeal stenosis. Alvaro, I think you're timekeeper. If you want me to blow through this, just tell me. Otherwise, I'll do this fast. So pharyngeal stenosis is like a step ladder. You cannot make it perfect. It's how many steps up the ladder you can get the patient. Can you get them a voice? Can you get them breathing without a tracheotomy? Can you prevent aspiration? Can you get them swallowing without a G-tube? And usually you can get someone 1 or 2 steps up that ladder, but not necessarily give them everything. And acquired pharyngeal stenosis is typically caustic or thermal injury. You've got recalcitrant scar. It's really challenging to swing tissue flaps because you're dealing with scar tissue. It's easy to unzip the scar bands, but you're left with lots of raw surfaces that want to re-scar. So how can you hold them open while they remucosalize? And so my idea was the Swiss roll pharyngeal stent. Most of these children have a trach and a G-tube already. So you place a very long suprastomal stent. The distal end is close to the trach tube. The proximal end is almost behind the soft palate. You place it endoscopically, put a stitch through it, then you pull it out the mouth and wrap a roll of silastic sheeting around it, and then you put it back in. And the silastic should be from the arytenoids to the soft palate, holding the raw surfaces apart while they remucosalize. and you remove it all 4 to 6 weeks later. And so here is a child with a grade 4 pharynx. There is nothing. You cannot see the larynx. And so this is as we start unzipping the scar. You can find the larynx, and you're trying to get through the worst of the scar bands. You're going to be having big raw areas everywhere. This will recur if you don't stent it. It's going to be almost impossible to swing flaps that have any meaning. And I'll just go through this a little faster. And so this is a composite stent. You've got a suprastomal stent all the way up behind the soft palate. You've got a roll of silastic sheeting wrapped around it, and it's holding that area open. This is pretty miserable for most children. The positive thing is that most children who've had a burn or a caustic ingestion have abnormal sensations, so they tolerate it better than you would think. And this is when we're removing the stent 6 weeks later. Stents out, looking reasonable. I mean, this is not normal, but you've got an open pharynx. And this is 1 year later, still open. And of course, this child still has a tracheotomy. They still have other problems. But we've been able to do a colonic interposition to connect to one side of the pharynx because we can now find the pharynx. So I'm going to leave it there. I'm not sure if there's any time for questions. I want to acknowledge all of the people who work together in this area in Cincinnati. And I think Sandro's up next. So thank you very much.
Gran conferencia, Mike. Gracias. Siempre tienes nuevos aportes. Impresionante. Y me gusta tu camisa. Álvaro, ¿hay preguntas del chat?
Sí. Tenemos algunas preguntas para Doug Seidel y tenemos un par de preguntas para Mike.
Pato, ¿cómo estamos de tiempo?
Estamos atrasados 15 minutos. Un par de preguntas muy breves, las respuestas, por favor.
Ok. Hay una pregunta recurrente para el Dr. Seidel y es ¿cuál es la dosis que él usa de Avastin sistémico y por cuánto tiempo?
Vamos con la pregunta para Mike. Parece que Doug no está en este momento.
Ok.
Sure.
Para Mike es solamente una pregunta y le preguntan cuánto tiempo después de la dilatación inicial él entra a quirófano a revisar el paciente.
So typically for a balloon dilation of a tracheal stenosis, I would like to do the next dilation within 7 to 10 days and the next dilation within 7 to 10 days. And if it's looking good at that point, then I start to make the time interval a little bit longer.
Thank you, Dr. Rutter.
Gracias, Mike. En honor al tiempo, vamos a continuar. Patricio va a coordinar la siguiente sesión. Adelante, Pato.
Buenos días. Gracias, Diana, por todo este trabajo. Y gracias a toda la audiencia. En este momento hay más de 800 asistentes conectados. ¿Se escucha bien, Diana?
Perfecto, se escucha y se ve perfecto.
Vamos entonces a continuar con la primera sesión que se refiere a parálisis congénita bilateral de cuerdas vocales. Es una sesión que dura en total más o menos 1 hora y después vamos a ir a un café, un Zoom Coffee. Quiero presentar al doctor Alessandro Alarcón, otorrinolaringólogo y cirujano de cabeza y cuello del Hospital de Niños de Cincinnati. Él nos va a dar una conferencia relacionada a un tópico de mucho interés, cuál es la parálisis congénita en el recién nacido, diagnóstico y alternativas de tratamiento. Bienvenido, Alessandro, muchas gracias por estar con nosotros.
Gracias, Pato y Diana. Es un placer estar aquí con ustedes. So thank you, everyone. It's really a pleasure. Thank you, Diana and Patricio. And I am going to share my screen. All right, can everybody see that? Does that look good?
Perfecto.
Great, so I'm actually filling in for Dr. Hart. As many of you heard earlier from Dr. Rutter, she's actually got detained in the OR. As many of you know, like everybody's lives have been changed pretty drastically by COVID. So we do a lot of sharing on our group. And that's probably one of the best parts about our team is we like to take care of each other and so cover for each other when we need to. So, you know, we also like to say we like to copy our mentors in some ways. So I've copied Mike, except I've gone to a different route for my disclosures, which is I get my money from the government. I have several disclosures with a couple of grants, one for papillomatosis with a collaborative group and one for a voice grant that was just funded. But really for what we're going to talk about today, really no conflicts. So thinking about congenital and bilateral vocal fold paralysis in general, it's fairly rare, less than 1 in 1 million live births. What you see with these children are dyspnea and exertion stridor. Frequently, they do get a trach at the very beginning of life, sometimes because they can't even extubate. They can have dysphonia in the context of this as well. Sometimes that's just because they can't move a lot of air through the glottis. Sometimes they have actually great voices. And their symptoms can mimic posterior glottic stenosis. So you really do have to look at these kids in the OR to make sure you're not dealing with a different disorder to begin with. As I mentioned, the differential diagnosis is subglottic stenosis, intraretinoid scar, posterior glottic stenosis, or cricoarytenoid joint fixation. So your microlaryngoscopy and bronchoscopy in these children is extremely important to really differentiate what their problem is, because that may change what you offer them in terms of a surgical treatment. So the endoscopic evaluation, we start with an awake flexible laryngoscopy. You anesthetize the larynx. The anesthetized larynx really cannot be trusted. We've had a couple of children that we've looked at in the operating room and thought that they had good function, and then you look a day later and they're swallowing fees test and they're bilateral paralysis and immobile. So we're big believers that you really need to look at these children awake and unanesthetized. And then you really want to see if you can see the posterior glottis. Sometimes you get lucky and you can see some hint of a scar band. You can maybe get a sense of maybe that the vocal folds are tethered, but frequently you really need to do your rigid bronchoscopy. And that's where you're actually going to go look in the posterior glottis. You're going to feel the cricoarytenoid joints and really see if they're stiff and see if that's your problem. You know, there's this association with subglottic scarring, which is quite frequent, and that can be just because they've been intubated and failed to extubate multiple times, and so they get this secondary problem. So what's that look like, you know, when you're thinking about your rigid and awake? So this is one of Dr. Rutter's patients.
Take a bite of the cookie for her, okay?
Here, I'll help you out with it. Here you go.
Take a bite of the cookie.
Girl.
So she's a 4-year-old girl, tracheotomy at birth, bilateral vocal fold paralysis. And what's really key is when you see her rigid bronchoscopy, you know, this is what she looks like asleep. You would never have any idea that she's actually got a vocal fold paralysis. You have to look at that bottom video where you can see that she's got a paralysis. So what are your management options? Well, you can trach them. It's very safe. You bypass the level of obstruction. And then you have some endoscopic options and you have some open options. I'm going to really talk about two particular types of options in terms of endoscopic options. We'll touch a little bit about open, and then there's several panelists that are going to give some talks later that give you some additional options for management of bilateral paralysis. So in particular with infants, the majority of infants are often, what we frequently do is tracheostomy and wait. After 1 to 2 years, if there's no spontaneous recovery, then we operate to remove the tracheotomy. And again, there's lots of different options, and you're going to hear a lot of those from different panelists today. So for your endoscopic management, it can be lysis and dilation. You can do mucosal advancement flaps. You can do a vocal process lateralization, a chordectomy, posterior costal cartilage grafting, and the open, you have those same options. And I think important things to remember is anytime you see lots of options for a disease process, it tells you that none of them are perfect, and that there's a lot of components that go into your decision-making about what you decide to do. So what are our preferences? Well, we tend to prefer doing posterior costal cartilage grafting. But within that context, we always think about, is there better options? And really, we have a lot of thanks to give out to Andy Inglis, who really pushed us to think about endoscopic posterior grafting. And that's something that we've also taken on in our practice as well. And so, when we think about the endoscopic indications, it's for patients that have posterior glottic stenosis, have bilateral vocal fold paralysis. They do have to have some must-haves, right? So they have to be easy to see endoscopically. If you have a grade 4 exposure, you're not going to do this endoscopically. You need to make sure that they don't have any medical or airway contraindications, right? So the child who may not have a tracheostomy but gives you 10 seconds anytime you try to do your microlaryngoscopy and bronchoscopy, it's going to be very hard to do that endoscopically. Then relative contraindications, if they don't have a tracheostomy, the advantage is you avoid an open procedure and a laryngeal fissure, and really kind of a similar complication rate. And this is sort of what you look for in terms of your patients pre-op versus post-op. And again, your goal is to give them a couple of millimeters, right? Trying to split that balance of giving them good airway, decent voice, and good swallowing, right? That's that sort of splitting that balance and making sure you're kind of trying to thread the needle. So what's it look like when you do this procedure? So this is our endoscopic grafting. We usually do our initial MLB, make sure that we can get the exposure we want. We go and harvest our costal cartilage graft. You suspend them. And then you want to split the posterior cricoid plate. We like to do this cold. As Mike mentioned in his talk, you can use a laser to do this. It's really, what your personal preference is. We tend to use cold instruments for this. Frequently, you'll find that the interarytenoid muscle is actually quite scarred, even in these bilateral paralysis patients, and you often find that you actually have to release that to really open up that space. Then you take your cartilage graft and then you insert it. You surprisingly will find that you often have to push harder than you think to get these to pop in. And once they're really in place, they may not come out. Occasionally, sometimes as you're trying to place these, you'll find that it's just too loose. And then you have to really try to secure these grafts. You can secure these with endoscopic stitches. It's super miserable to do, but you can do it. And it's something you should also keep in your armamentarium. If you're finding that your graft is really unstable, you should consider securing it endoscopically or placing a stent for a while. So, and again, the key pieces about the graft is we like this keystone shaped graft because it helps get gripped by that posterior cricoid plate when you insert it. Stenting. So for single stage, increasingly, we're trying to do shorter periods of intubation. So sometimes trying to do less than 5 days. A suprasternal stent will often leave from anywhere from 3 to 4 weeks. And then long-term stenting is really probably more applicable when there's a posterior split without graft or someone who's multi-revision, where you may consider something like a T-tube for children over 4 years of age. And again, just getting an idea of what this can look like. As you saw kind of earlier, your exposure, really getting a good sense of what that looks like, doing your split, and then your post-op when you have your graft really in place. I'm going to move along just to save time since you've already seen the video of splitting the posterior plate. And then endoscopically, you can always check it, which is a nice piece to just kind of see what that looks like. So posterior grafts are great, but they have their downsides, right? And typically the bigger downside can be the risk of aspiration in some children, and then the risk of some voice problems post. So we always think, is there a better option? And so parallel evolution about thinking about, infant LTR. In infants with acquired subglottic stenosis, we do an anterior thyroid allograft and a posterior cricoid split. So the thought was, well, what if we did something similar for some of these kids with that present with bilateral focal fold paralysis? And again, this is the single stage version of doing the thyroid allograft, what the post looks like. And so thinking, well, what if we can just sort of break sort of the spring of that posterior, of that cricoid, and give them a little more space. And, in early evolution, this is the part where sometimes your mentors get to try to do something. So we tried just doing an endoscopic anterior split, which really just didn't work, right? And why didn't it work? And it was really thinking about this concept that the cricoid is a spring, right? So, and then you get almost like this bulldog clamping. So if you only split one area, it's really not going to work. You really have to split both. And once you split both, you get this piece of you really kind of break the bulldog clamping, and then that anterior cricoid can actually relax. And so that's where we came up with the anterior and posterior cricoid split. You suspend them in a Lindholm. You put in vocal fold spreaders. This is a child with bilateral vocal fold immobility. This is their endoscopic evaluation. You can split with a blitzer or D-blade. Then you can use endoscopic scissors. Then you do your anterior split. You can use a balloon to help break that cricoid. Then you intubate him with the largest endotracheal tube you can through the nose. So the nose is the limiter. Typically we do a 4 or 4-5, and then we intubate them for 10 to 12 days. Really key to try to get that 10 to 12 days, because if you try to go shorter, you will find that you end up having to do more endoscopic intervention just to keep it open. And here's just a sequence of some videos to just kind of illustrate your exposure with a Lindholm, doing your split, again, using a D knife, which can be really useful. Typically you have to push a lot harder than you think, and this tends to work a little bit better than the blitzer. And then you really have to almost saw on that cricoid to get it to split. And then your anterior split, typically when you're doing this, we'll do it with a blitzer, and you'll use your opposite hand to sort of push down on the cricoid and kind of score it until you can kind of break that anterior cricoid ring. And lastly, just using a balloon can sometimes facilitate this, that once you've kind of indented or really marked those areas and sort of weakened them, the balloon can finish your breaks.
Where are you going?
So what did those results look like in these patients? So we've done about 19 infants, mean age about 4.7 in terms of their months, all tracheostomy candidates. 14 were successful, 3 required trachs, 1 eventually required a posterior graft, and 1 was non-airway death. It's also really important to know that you have to follow these children. What we see is for the ones who are the kids that are going to grow out of their paralysis, meaning they're going to regain some of their function, we actually get them to that point and they regain some function. Sometimes you see for the kids that maintain a paralysis that you end up having to go back and doing further procedures, but you end up having to do it electively. That was the case with one of our kids that ended up with a posterior graft, and you can kind of choose and do the time that you want to do it. So it's as an outpatient, it's not emergently. And this is the pre-above, this is the post, super quiet infant. This is sort of the goal. And again, sometimes you need to do supraglottoplasty too. They can get in some kids where you have additional problems in terms of airway obstruction. And really it's that piece that you just give them enough opening in the posterior glottis to get away with it, and they don't have as much of the voice issues or swallowing issues as you have when you fully expand them with something like a graft. One of the evolutions really recently has been to think about, well, what if we could actually just put in some tissue to help expand it? So we've actually used in a couple of cases an expander, which is just using a little piece of folded over mini plate that we use for facial fractures. You actually have to create a little tunnel when you do your division with scissors, so that way you have a mucosal bridge so it doesn't pop out the little piece of the spacer. We have had one or two that may have popped out partly because of that piece, and then you have to close it with an endoscopic stitch. And then you can see the post video on your right. So that's another alternative in terms of not having to do an A and P split. And advantages of this is that you can do far shorter intubations because you're actually spacing that with tissue that gets absorbed over time. So in conclusion, thinking about the AP split as a really viable alternative to tracheostomy in these really young infants to get them through that period of when you think they may grow out of their bilateral vocal fold paralysis. Obviously, that we always are thinking about guidelines about who are our ideal candidates. And then you can always rely on tracheostomy as an alternative for these children. And then you can see this nice photo that Mike showed earlier as well of the airway descendants from our team in terms of from Robin all the way down to Matt Smith, who is our newest member, all in Mike's favorite Hawaiian shirts. But I think it's one of the really nice things about our team is that we work really well together and that, many of us have sort of trained from each other and learned from each other. And it's a really great environment to be in. And then Cincinnati Children's, which continues to grow with actually a new tower that's just in the midst of all this still going up and should be ready in the fall of 2020, where we're adding about 220 beds that are all critical care. So thank you, and I'll release back to Patricia and Diana.
Muchas gracias, Alessandro, por tu excelente conferencia, muy entretenida, muy interesante, con mucha actualización. Vamos a dejar todas las preguntas para el panel, vamos a tener tiempo para las preguntas del chat y vamos a continuar entonces con nuestro programa. Les quiero decir que estamos bien en el tiempo, estamos en el tiempo exacto del programa y voy a invitar entonces a nuestro siguiente panelista, el doctor Patricio Beliá, de Argentina, quien nos va a enseñar un video de una técnica de lateralización cordal. Patricio Beliá, ¿estás con nosotros? ¿Puedes conectarte?
Sí, Pato, acá estoy.
Lateralización percutánea de cuerdas vocales en parálisis cordal.
¿Se ve bien ahí?
Muy bien.
Ok. Buen día a todos. Gracias, Pato. Gracias, Diana, por la invitación. Como dijo recién Pato Varela, el doctor Varela, voy a hablar de lateralización cordal percutánea bajo control endoscópico. Esta es la imagen de nuestro hospital. Hace aproximadamente 10 años tuvimos una paciente de 15 años que tenía un carcinoma tiroideo, el cual comprometía el nervio recurrente izquierdo. En el posquirúrgico inmediato de la tiroidectomía se intentó extubar, fracasó, fue a la terapia. Al día siguiente volvieron a intentar la extubación, volvió a fracasar. Entonces la evaluamos, tenía una parálisis bilateral de cuerda vocal, y basándonos en este trabajo que había sido publicado en el año 2004 por gente de Nueva Delhi, de la India, en el Pediatric Otorrinolaryngology, que hablaba de la lateralización por punción, ideamos esta técnica para tratar a nuestra primer paciente. ¿Cómo lo hacemos? El paciente en quirófano con laringoscopía de suspensión. Vamos a necesitar 2 operadores, uno que realice la laringoscopía y otro que va a realizar la punción percutánea. Dependiendo de la cuerda que vayamos a lateralizar, lo que tenemos que tomar en cuenta es que si lateralizamos la cuerda vocal izquierda, nos vamos a posicionar del lado derecho, la torre de imagen va a estar del lado izquierdo, y vamos a utilizar un Avocat 16 o 18 dependiendo de la edad del paciente y un Prolene 2 y 3 ceros. Entonces, como les dije, el paciente con laringoscopía de suspensión, un operador para realizar la laringoscopía, el otro la punción. En este caso vamos a lateralizar la cuerda vocal izquierda, la torre va a ir del lado izquierdo y el que punza del lado derecho. Vamos a usar un Avocat con una jeringa, porque a veces se tapa con el cartílago, atravesamos el cartílago derecho por debajo de la cuerda vocal izquierda a la altura de la apófisis vocal, saliendo por el lado izquierdo y atravesando la piel. Ahí vemos cómo atraviesa el Avocat las dos alas tiroides. Introducimos un Prolene 2 ceros, retiramos parcialmente el Avocat y recuperamos ese Prolene de la laringe sacándolo por la boca. Ahora redireccionamos el Avocat para que pase por el borde superior de la cuerda vocal a la altura de la apófisis vocal, saliendo de nuevo hacia el lado izquierdo. Volvemos a observar que atravesó las ambas alas tiroideas. Introducimos el otro Prolene en forma de lazo, el Prolene 3 ceros. Tiene que ser más fino porque va en forma de lazo. Retiramos por completo el Avocat y volvemos a recuperar ese Prolene de la laringe sacándolo por la boca. En este lazo vamos a introducir el otro cabo del Prolene que pusimos primero y vamos a traccionar desde la izquierda para poder sacar ese cabo y de esa forma lazar la cuerda y lateralizar la cuerda vocal. Vamos a hacer una incisión para suturarlo en el tejido celular subcutáneo y controlamos la lateralización. Obviamente que esto es posible si el paciente no tiene sinequias. Esto es exclusivamente para una parálisis bilateral de cuerda vocal. Bien, ¿cuál es el resultado de la voz? Esta es una paciente de 3 años que se había traqueotomizado por una parálisis congénita y para poder decanularla le hicimos este procedimiento y esto es el resultado de la voz.
¿Cuántos años tenés? Un poquito más, así me parece.
¿Cómo te llamas?
Ven que la voz no se altera en lo absoluto. Entonces, para concluir, es una técnica que produce poco daño laringio, es eventualmente reversible. ¿Por qué eventualmente reversible? Creemos que en el posquirúrgico inmediato, si uno suelta el punto, la cuerda vocal vuelve a su posición y esto no va a pasar si lo hacemos en el posquirúrgico lejano, ¿sí? Se va a anquilosar la articulación cricoaritenoidea y no va a volver la cuerda. No tiene alteración de la voz y es fácilmente reproducible. Este es nuestro equipo de trabajo. Ahí estamos los 7 que hacemos vía aérea en el hospital. Y bueno, muchas gracias.
Muchas gracias, Pato. Excelente presentación, un video muy claro, se vio muy bien, estamos con bastante buena transmisión, los videos los hemos visto correr perfectamente bien. Agradezco nuevamente a todos los panelistas y antes de continuar con la siguiente conferencia, y ya les decía que vamos a dejar preguntas, tenemos tiempo para preguntas durante el panel, las preguntas que existen ya en el chat. Quiero comentarles, estamos muy contentos, hay 878 asistentes conectados. Esta es una cifra bastante impresionante y esperamos que todos nos puedan estar siguiendo con buen audio y con buena imagen de video. Son 52 los países que están representados, prácticamente todos los continentes, y eso nos tiene, por cierto, muy contentos. Quiero continuar con nuestra siguiente invitada, la doctora Marilena Trozzi, del Hospital Bambino Gesù de Roma, Italia. Calculo que allá deben ser las 4 de la tarde más o menos. Por lo tanto, Marilena no ha tenido que madrugar como nosotros. Bienvenida, Marilena. Esperamos tu presentación.
Thank you very much. I don't know if I'm already sharing my screen. Can you see my screen properly?
Yes.
Okay, perfect. So I'd like to thank, of course, Patricio and Diana for including me in this amazing conference. One day I will be able to say I was there for the first Zoom international conference. So I go quickly to share my video so we can save some time for the question at the end.
Whoever have challenged the treatment of the bilateral vocal cord palsy in pediatrics have experienced a slight sense of frustration related with resulting patent airway but poor quality of voice. And when this is involving young girls, otherwise healthy, the frustration has grown proportionally to the unsatisfaction of the parents. We have experienced this frustration many times until a colleague parent of a 2-year-old girl with bilateral vocal cord palsy, extremely worried for her voice, picked my attention on this paper. It describes only 4 neonatal cases treated by this new technique and a new device, but with no report of the quality of voice. What raised our attention was in particular the rationale behind the technique. For years, we have focused our attention in spread the vocal cords or cut part of it, but we forgot what we knew about the physiological movement of the arytenoid. That is not at all a linear movement, but it used to be said that the arytenoids rock, glide, and rotate. This technique aims to reproduce and fix the vocal process of the arytenoid in the natural end position of abduction. By doing this, allow the cord to maintain its natural tension, an excellent respiratory space, and no interference on the vibratory wave with excellent results on the voice. To perform this surgery, we need to use a Lindon-modified thread guide that we call ROVO, from the name of the Hungarian colleague who thought about this technique and adapted the tool for this purpose. I'll show you a short video of the technique to let everyone know that if you are familiar with the endoscopic pediatric laryngeal surgery, this technique requires a short learning curve. It is relatively easy and fast, in front of a great satisfaction in the results. After selecting the side that looks stiffer at the palpation, we proceed with an incision by a beaver blade in the cricoarytenoid joints capsule. The thread guide is led to the glottis level just below the vocal process to allow the built-in curved blade through the incision in the cricoarytenoid joint and then push through out of the surface of the neck. A 2.00 Prolene is laced through the hole at the tip of the blade, then is pulled back with the blade into the laryngeal cavity and pushed about the vocal process to the outer surface of the neck. The ends of the thread are not under the skin with a simultaneous visualization of the correct abduction of the arytenoid. In this case, we have removed the tracheostomy and the thread in 4 weeks. At the control 6 months after, it seems she has recovered a tiny movement on the opposite side of the lateral abduction. I'd like to let you evaluate the voice results by yourself. This is the voice of the girl before the surgery.
1, 2, 3, 4, 5, 6.
And this is 1 year after the lateral abduction.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
She has been decannulated, able to play, dance, and run with finally a satisfactory voice quality according to the kid, to the parents, and to us. We've been performing the same surgery on 15 kids with different age, comorbidity, and previous surgery on the larynx. 10 were already tracheostomized, and they have been all decannulated within 4-8 weeks maximum, with a very few minor complications. And 5 undergone to lateralization without the support of tracheostomy, with not even minor complications. This one had a significant improvement in all the functional tests as a maximum phonation time, lung function test, and ODI. The voice quality analysis showed general stability in the parent perception of the kid's voice before and after the surgery, with 3 significant improvements, and the only 2 reported as a worsening were the only 2 who didn't follow the protocol of postoperative speech therapy and rehabilitation. Gerber's scale is quite consistent with the parent's perception. In conclusion, this technique jumped quickly at the top of our favorite approach to bilateral vocal cord palsy because it's safe, fast, endoscopic, indicated even in case of posterior stenosis or cricoid joints fixation, no aspiration issue, and we think finally good voice results. Disadvantages at this time of the experience, we do not think is reversible as the Korean group described in their experience, but we are convinced that it does not prevent future treatments. The numbers are still limited, but we definitely think that deserve to be considered in your practice.
Thank you very much.
Muchas gracias, Marilena. Excelente presentación. Gracias por el tiempo. Los videos estuvieron fantásticos, corrieron perfecto. Valió la pena todo el trabajo que hemos hecho en este tiempo. Los felicito a todos los speakers por sus presentaciones nuevamente. Antes de ir al panel, quiero decir algunas cosas para los asistentes. Esta es una modalidad webinar, por lo tanto, lamentablemente ustedes no pueden acceder a la cámara ni al audio por este momento. Sin embargo, al final del evento vamos a abrir muchos de los videos y cámaras, todos van a poder aparecer en pantalla, poder interactuar, hacer preguntas o comentarios. Eso lo vamos a hacer al final. Espero, sin embargo, que todos estén escuchándonos bien y espero que tengan buena imagen. Estamos conectados a Facebook también. Y vamos a continuar entonces ahora con el panel, y después del panel vamos a ir a un café. En este panel, por cierto, que va a haber tiempo para preguntas, que recuerdo, las tienen que realizar a través del canal de preguntas. ¿Estamos bien con la imagen, Diana?
Perfecto, estamos muy bien.
Entonces, continuamos. Este panel debería durar 30 minutos y después habrá tiempo para el café. Bien, nuestros panelistas, ustedes ya los conocen, la doctora Catherine Hart de Cincinnati, Alessandro Alarcón, Marilena Trozzi, Patricio Beliá y Diego Preciado de Washington, D.C. Quiero comenzar con un caso clínico, un video. Coloquen sus audios, por favor, y vamos a comentar a continuación, vamos a pedir la opinión al panel y también al chat. Este es un recién nacido que tiene 10 días de vida y que presenta obstrucción respiratoria desde el primer día de vida, con un estridor de tonalidad alta, agudo, con dificultad respiratoria, con retracción supraesternal y retracción de la caja torácica. Presenta algunos episodios de desaturación durante la noche, ha requerido oxígeno y desatura también durante la alimentación. Vamos a mostrar ahora el video. Es solo un caso. Como ustedes pueden ver, presenta estridor de predominio inspiratorio, está en algo de distrés, con marcada retracción supraesternal y torácica. El siguiente examen es una nasolaringoscopía con el paciente despierto, siguiendo las indicaciones también que señalaba Alessandro en su conferencia, y ustedes podrán ver en esta nasolaringoscopía los hallazgos. Existe un cierre de la glotis durante la inspiración, 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 inspiración. Cada vez que el paciente inspira, cada vez que nuestro recién nacido inspira, existe un movimiento paradojal con un cierre de las cuerdas vocales secundario al fenómeno de Bernoulli. Esto es categórico de una parálisis congénita, una enervación total de la laringe, con un cierre durante la inspiración. Está de más decir, no está de más decir que normalmente durante la inspiración, las cuerdas deberían abrirse. Acá, paradojalmente, las cuerdas se cierran. Vean ustedes la condición de este recién nacido después del examen, después de la nasolaringoscopía. Es decir, después de la nasolaringoscopía existe aún más obstrucción con una marcada retracción supraesternal, marcada retracción de la caja torácica e incluso se pueden fijar, pueden apreciar uso de la musculatura abdominal. Bien, entonces quiero invitar al panel, pero quiero invitarlos a todos ustedes, a los asistentes, a que hagamos una encuesta. Esta es la parte que nos entretiene más, tal vez. Y acá ustedes van a participar y se van a sentir más cercanos a todos y entre todos. Entonces, en la encuesta, esta es la primera, y quiero que ustedes, concentrados en este paciente que he mostrado recientemente, ¿cuál sería la conducta, cuál sería el tratamiento en vuestros centros? ¿Cuál ha sido la experiencia en los centros donde ustedes trabajan? O si no han tenido la oportunidad de tratar a un paciente de esta característica, ¿qué es lo que harían ustedes al recibir un enfermo, un recién nacido con esta patología? ¿Harían una traqueostomía? ¿Harían algún procedimiento endoscópico o quirúrgico? Por favor, en la encuesta que van a ver a continuación, elijan solo una opción, marquen solo una opción. Diana.
Vamos a darles unos segundos más. Que se estabilicen un poco los resultados.
Entiendo que los panelistas no están habilitados para votar, Diana.
No, no están habilitados. Sería un sesgo.
Esto es un privilegio para los asistentes. Creo que ya estamos. Casi.
Estamos. Vamos a compartir los resultados. Bueno, 74% traqueostomía, 25% procedimiento endoscópico y un menor porcentaje cirugía abierta.
Perfecto. Continuamos. Y muy interesante la información que hemos recibido. 74% de la audiencia sugiere una traqueostomía, un 25% un procedimiento endoscópico y un porcentaje menor cirugía abierta. Han votado 471 personas. ¿Continuamos, Diana?
Continuamos. Dale, continuamos.
¿Quieres hacer algún comentario, Diana? Álvaro.
No, adelante, Pato.
No, estamos ok.
Bueno, entonces continuamos con nuestro panel, ¿les parece? Quiero preguntarle a nuestro panel, después vamos a ir al chat nuevamente. ¿Qué haríamos con este recién nacido? Esperamos, tiene 10 días, yo les decía, obstrucción respiratoria, estridor muy marcado, parálisis de cuerdas vocales. No hay otras patologías, no hay lesiones neurológicas, es un niño sano con una parálisis cordal solamente. un problema grave, por cierto. ¿Esperamos, hacemos una traqueostomía o realizamos algún procedimiento? Y quisiera darle la palabra a Diego Preciado. Diego, ¿estás ahí?
Sí, hola, ¿me escuchas?
Sí, Diego, muy bien. Te quisiera
¿Qué tal?
preguntar, Diego, bienvenido. Los que se han integrado recientemente y no pudieron estar durante la introducción de este evento. Diego es otorrino, trabaja en el Hospital de Niños de Washington y es actualmente el presidente de la Sociedad Americana de Otorrinolaringología y Cabeza y Cuello. Bienvenido, Diego, muchas gracias. Y quería preguntarte, ¿qué te pareció el video? ¿Qué harían ustedes o qué hacen ustedes o qué has hecho recientemente con estos niños? ¿Y cuál es tu impresión de la votación de la encuesta? ¿Eso refleja en cierta medida lo que se hace en general en Estados Unidos y en los países latinoamericanos que has visitado?
Hola Pato, primero quiero felicitarte a ti y a Diana por organizar este tremendo evento. Verdaderamente, aunque la situación de COVID es triste para todos, poder reunir 900 personas impromptu en una webinar de esta índole con expertos del mundo que ya han presentado es increíble. Así que te felicito y gracias por invitarme a ser parte de este grupo. Te voy a contestar en español. Si hablamos con los panelistas en inglés, hablaré en inglés, pero ya que estamos hablando en español, te voy a continuar en español. Pienso que la parálisis bilateral infantil, el video que muestras muestra una patología bastante severa de un punto de vista de síntomas, ¿no? Una de las opciones que me parece que no mostraste en el poll es tal vez no aplicable a este paciente, pero es la observación y el tratamiento conservador. Hay muchos pacientes de parálisis bilateral infantil que pueden mejorar de una forma temprana o que se pueden manejar conservadoramente. Este paciente me parece que no cabe en esa categoría. Y otra cosa que te diría que está entrando a disposición en la evaluación de los bebés con problemas de movimiento de cuerda vocal es el uso del ultrasonido. Es una forma no invasiva que hemos empezado a utilizar ahora en la época de COVID. Hay una curva de aprendizaje e inicialmente puede ser un poco más dificultoso mirar o ver el movimiento de la cuerda vocal, pero es una opción capaz menos invasiva que la nasofaringoscopía, que obviamente es el gold standard, nasofaringoscopía despierta para estos niños. Me parece que la evaluación completa es importante, una broncoscopía, asegurar que no haya otra lesión, eso es muy importante y me parece que mencionaste que no la hay. También una resonancia del cerebro, del tallo del cerebro es importante para asegurarse que no hay una lesión neurológica. Me parece que mencionaste que tampoco la hay. Entonces, considerando una evaluación, muchas veces mandamos una evaluación genética. El paciente obviamente está hospitalizado en cuidados intensivos, se lo observa, se ve qué tan severa es la patología, si se desatura. En el caso que mostrás, parece demostrar una sintomatología bastante severa que parece necesitar intervención. Y para contestar tu pregunta en sí, yo diría que en nuestro centro hemos tratado métodos endoscópicos en el recién nacido, como se ha publicado de Cincinnati. Creo que el doctor Seidel, que habló antes, también tiene una serie que es la división del cricoide endoscópicamente anterior y posterior. Y solamente hablando de mi opinión y mi experiencia, no hemos tenido buenos resultados en los pacientes que necesitan intervención con esa intervención. No los hemos tenido, no hemos tenido éxito en prevenir la traqueotomía. Entonces, mi manejo de estos pacientes coincide o concuerda con el resultado de la encuesta, que sería, si es necesaria, la traqueotomía es bastante lógica en este sentido, ya que no es una cirugía destructiva, no viola, digamos, la anatomía natural de la laringe y le da una oportunidad o una chance al recién nacido que recupere su movimiento. He visto recién nacidos que recuperan movimiento de una forma temprana, en los primeros 3-4 meses de vida, y algunos que pueden demorar aún más. La intervención en nuestro centro la hacemos a los 18 meses como lo más agresivo o lo más temprano que haríamos en una intervención. Y luego podemos hablar de las intervenciones, porque en eso también tengo opiniones cuando hablamos de intervenciones endoscópicas en ese sentido versus abiertas. Lo que te diría de la intervención endoscópica en el recién nacido, que sería la división del cricoide endoscópica, pienso que es cierto que más adelante, digamos que no es exitosa, es cierto que más adelante en el futuro uno puede igual poner un injerto posterior, digamos, o hacer otra intervención, pero sí creo, y esto es, hay que tomarlo en consideración, que al dividir el cricoide endoscópicamente uno está introduciendo cicatriz a la laringe de un recién nacido que puede sanar de una forma no predecible, que puede hacer, y esto es teórico, pero es mi impresión, puede hacer que el efecto o la técnica de poner un injerto posterior más adelante en el futuro de ese niño tenga menos éxito, o sea, más dificultoso. Por ese motivo me parece que la intervención o conservadora o con traqueotomía es la opción correcta en el paciente que mostrás. Y uno puede errar de ser demasiado agresivo en estos bebés.
Muy interesante lo que has comentado, Diego, muy claro, completamente de acuerdo. Y bueno, en esto hay controversia, pero la recomendación, por cierto, la traqueostomía, que para muchos a veces puede ser frustrante no poder ofrecer otra alternativa, no debería serlo, porque la alternativa la vas a ofrecer más adelante si es que la necesitas. Quiero agradecerte nuevamente, Diego. Sigues con nosotros. Y Alessandro, ¿podrías encender el micrófono? Catherine Hart debería estar en este panel, pero lamentablemente ella está en el quirófano. Esperamos que se pueda incorporar. Alessandro, nuevamente felicitarte por tu conferencia y el trabajo que ustedes realizan. Quisiera preguntarte dirigidamente qué harían ustedes con este recién nacido. Muchos de los videos que nosotros vemos son pacientes que ya tienen una traqueostomía y sin duda que es más accesible la vía aérea. Debo suponer que en un recién nacido como el que yo he mostrado, que tiene una obstrucción de la vía aérea, intentar hacer procedimientos endoscópicos en respiración espontánea debe ser un poco más complicado. Pero te quisiera preguntar más de la técnica, la colocación del injerto, el split, si pudieras dar algunos detalles. Ese injerto que colocas atrás cuando haces injerto, ¿es un injerto que se coloca en la misma posición que los injertos que colocamos para las estenosis subglóticas o es un injerto que va un poco más arriba? Gracias, Alessandro.
Thank you, Patricia. Great questions. And I want to thank all the panelists that are here and their great talks from before, and Diego for bringing up some also valuable information as well, that observation is a potential in some of these children if they are not quite as symptomatic as the case that you've presented, Patricio. But you do have to, as Diego mentioned, work them up pretty extensively and make sure that the family is actually capable of sort of watching that child to see if they can manage them at home. In regards to what we would do with a child like this, you know, we would do an endoscopic AP split as a first step. Child has no tracheostomy. If it's truly just the paralysis, we would use that as a first step in it, and to see if it works and we can get away with it. Sometimes it doesn't work and it's not enough, and then you have to consider other options, right? So frequently with the smaller infants, we may go to a tracheostomy as a second step if the AP split doesn't work. Or in some cases, we would also even consider like a small posterior graft endoscopically. It is a lot harder to do it in these really young infants, although it is possible. I think the youngest infant that we've done, I want to say is 2 months of age, so it is doable, but it's not a super fun experience in terms of trying to get the graft in and get it to fit, and the ribs are pretty tiny, right? In terms of that that location of the graft, that is a great point, Patricio. Very different than when you're doing with subglottic stenosis. The graft has to come high, meaning it has to extend all the way through the vocal fold level. If it is below, sometimes you just won't get the effect that you really need in terms of expanding that airway. Typically, the width that we like to shoot for is around the 4 to 5 millimeter range, mainly because if you go bigger than that in these younger children, you're going to have significant voice issues with those children. So the really big grafts are the ones where you get kids that are almost completely aphonic. And they're a little harder to deal with in terms of voice. There are some good surgical options where you can actually undo a posterior graft to regain some voice. I think that's probably why one of our preferences for us as a posterior graft is we can undo it now. We have a good procedure to undo it endoscopically. So later on, you can do something for them. I do think that that's an important piece, and I want to thank and tell Marilena, like, great work. I love seeing, like, you know, getting the voice outcome pieces like put together. I know I've been pushing you. You need to publish that. That's important, you know, to show that we're capturing all outcomes when we're looking at these children. But I would also say make sure you follow them long term. Because one of the things we see with these children in general when we do vocal fold procedures to expand the airway is their voices get a lot worse when they go through puberty, because their larynx grows, and what you see is those spaces get even bigger that we created. And it's not uncommon that you get them coming back to you at a point saying, you know, all of a sudden they went through a growth spurt through puberty and the voice got a lot worse. So you really have to follow these families for a long period of time, because sometimes what you think is that they can have a great voice outcome in the beginning, and then it gets worse when they go through that pubertal growth spurt. And very important to do that.
Muchas gracias, Alessandro. Ha respondido todas mis preguntas. Es un tema apasionante que nuestro equipo lo maneja y lo trata el otorrino, el doctor Pacheco. Nosotros somos asistentes en esa patología. Quería hacerle una pregunta a Marilena. Marilena, ¿puedes encender tu micrófono? Marilena de Roma, del Hospital de Niños. Marilena, en el procedimiento que han mostrado recientemente, endoscópico, el instrumento que utilizas está disponible en el mercado, es muy diferente al Listerberger que conocemos, y el procedimiento que han mostrado difiere en algo al procedimiento que ha mostrado el doctor Beliá, o es exactamente el mismo principio. Te pregunto también respecto del material de sutura que utilizas en la lateralización, y entiendo que mencionabas que lo retirabas después de un tiempo.
Yes, so thank you for the question, because it gives me the chance to go a bit more in detail about the technique. First question. Yes, we we start from the last one. Yes, we remove the stitch, we remove the thread, we use a non-resorbable thread, because that what I learned from the Hungarian experience. That was the only one that did this technique. And in terms of this sort of recovery, the Prolene stitch give us the chance to remove or not remove according to the compliance of the patient. We had some cases where the voice was really bad after the first month. And we prefer to remove, because the space that we obtain at the end of the procedure was probably too wide. So because our main goal was the quality of voice, even if of course the principal outcome was decannulation or giving a good airway pipe, we more or less we remove 80% of the stitch in our patient. We kept only in the patient that looks really well balanced in terms of quality of voice and space of breathing. So the other question is about the instruments. The instruments, according to what I know, is available because they sell the copyright from Hungary to UK. So now is a UK corporation that is giving and selling and spread, and that make a bit more easier for the certification, and it's not expensive. The main difference is thicker than Lindom instruments. So the Lindom instruments has a consistency, as a sides that doesn't allow to pass through the thicker part of the cartilage. So it was perfect to pass the stitch through the middle, in the middle of the vocal cord, where the thyroid cartilage is a little bit thinner. The long arm of the Lindom is too thin, so there is a sort of elastic. You can push the needle through the cartilage, where in the back of the thyroid cartilage. That said, it's too thick. But the goal of these instruments, the ROVO, is that we want to pass above and below the vocal process of the arytenoids to simulate the movement of the abduction. So that's the main difference. According to the colleague that presented the lateralization, I think on principle is pretty similar. If it works exactly in the same way. It's just that this specific technique, the ROVO technique, is super easy, especially in newborn. We did very few under 1 year old, but the 3-month-old kids that we did it was fast, easy, and we don't even need to cut the cricoarytenoid joint because it's super mobile. There is no cricoarytenoid joint fixation in those patients, so we don't need to open that cartilage. We just need to pull a bit the arytenoid in a better position. So in the case that you showed earlier on, we probably propose something conservative at the beginning, like intubation, extubation, see how long it lasts to give it a chance. Maybe a non-invasive ventilation for a little bit time just to see if it can manage. But if nothing works and we quite sure that is a stable paralysis, we probably propose a lateralization. We're not used to do that earlier than 2 years ago. We always propose a tracheostomy, and we are not against the tracheostomy in principle. We think it's the best option in many cases, but for otherwise healthy kids like this one, I would probably propose to the parents if they want to do something like that. But we have to make them prepare that we are causing a scar in any case. So it's not clean of any complication, or tracheostomy is bad for the parents, but it's very good for the kids because you don't touch the larynx. So it's open to every kind of surgery. But in the in the choice of all the options, I think is the less invasive. The less invasive is tracheostomy, and then the lateralization is pretty safe.
Ok, muchas gracias Marilena, muy claro. Te quiero decir que hay varios italianos escuchándote a través de, lo he sabido a través del chat, tienes tu torcida propia, tus fans, y quiero preguntarle al doctor Beliá y luego vamos a ir al chat. Y después del chat vamos a hacer una encuesta final y después al café. Patricio Beliá, yo te quería pedir, no sé si puedes eventualmente primero hacer algunas preguntas. ¿Quieres agregar algo? Tú decías que retirabas el material de lateralización que habías utilizado. Quiero saber si tú a este niño tan pequeño, con tanta obstrucción, ¿intentarías una lateralización percutánea o irías directamente a una traqueostomía? Quizás puedas responderme estas preguntas mostrando el video. ¿Es posible? Solamente el video, Patricio, es un video muy lindo, 3D, donde se puede apreciar muy bien y desde el chat ya lo estaban pidiendo.
Ok, Pato, sí, ahí lo comparto nuevamente. ¿Se ve ahí?
Sí, y puedes responder las preguntas quizás durante...
Sí. Ahí arrancó. Bien. A ver, con respecto a retirar el punto, nosotros no retiramos el punto si el paciente anda en forma favorable. ¿Qué es que ande en forma favorable? Que tenga buena ventilación, buena calidad de voz y buena deglución. Con este paciente puntualmente, nosotros haríamos lateralización cordal como primera opción. ¿Y por qué? Porque si no funciona, sí podemos retirar el punto y volvemos a foja cero. La lateralización cordal en el posquirúrgico inmediato no genera cicatriz, no te genera ningún tipo de alteración persistente en la laringe. Y yo puedo evaluar en un tiempo corto, alrededor de un mes, cómo deglute, cómo respira y qué calidad de voz tiene. En este paciente puntual, ya que no está intubado y tolera mal, pero tolera la extubación, yo creo que la lateralización o cualquier procedimiento que expanda no mucho la cuerda vocal podría mejorar. Esto no quiere decir que la primera opción sea esta. La primera opción también creo que sigue siendo la traqueotomía, fundamentalmente en la parálisis bilateral idiopática porque tiene una alta chance de recuperación. Pero nosotros intentaríamos lateralizarlo para evitar la traqueotomía y con esta posibilidad de que si no nos gusta la calidad de voz y el paciente no deglute bien o no mejora su dificultad respiratoria, sacamos el punto, volvemos a cero, no pasó nada y en ese caso lo traqueotomizaríamos.
Muchas gracias, Patricio. Ha respondido todas las preguntas. Puedes dejar de compartir la pantalla quizás.
Ahí estamos.
Tenemos 10 minutos para ir a las preguntas del chat. Quiero agradecer nuevamente a todos ustedes, a los asistentes también, van a tener la oportunidad de preguntar y vamos a hacer una encuesta final y luego al café. Estamos bastante bien en el tiempo.
Pato, quiero hacer un comentario. Por favor, las personas que han solicitado levantando la mano, hacer las preguntas por el botón de preguntas y respuestas para que puedan ser transmitidas a los conferencistas. Gracias.
¿Alguno de los panelistas quisiera hacer algún comentario antes de escuchar las preguntas del chat? Si alguno de ustedes, panelistas, quisieran, levantan la mano. Álvaro Pacheco.
Sí, señor, aquí estoy.
Tenemos 10 minutos para
perfecto.
preguntas y respuestas.
Tenemos varias preguntas del chat. Hay una pregunta que es recurrente, hay 3 o 4 personas que han preguntado lo mismo, y es si la sutura que se utiliza para la lateralización puede producir algún daño en la cuerda, si es capaz de dañar la mucosa o derechamente cortar la mucosa y producir daño en el músculo vocal.
¿Quieres contestar, Marilena o Patricio Beliá, esa pregunta?
En nuestro caso no vemos lesión. Había escuchado que en algunos casos cortaba la cuerda vocal. En realidad el músculo, el punto va sobre la apófisis vocal, no va sobre el músculo. Igualmente, si fuera sobre el músculo, es un músculo muy potente. Nosotros no realizamos cordectomías hace muchos años ya, pero en algún momento donde la hemos realizado, vos cortás la cuerda vocal y la mirás al poco tiempo y la cuerda vocal parece que no la tocaste con nada. No creo que el punto dañe la cuerda vocal en absoluto.
Marilena?
Same year, we don't have any of this kind of complication. I think that was the traditional lateralization, that one made with a Linden instruments that goes in the middle of the vocal cords. So that's where we used to see granulation or disruption of these waves, the mucosal waves of the cords that cause, of course, complication.
Muchas gracias. Quiero aprovechar de dar la bienvenida a Catherine Hart, que se ha incorporado al panel. Catherine estaba en el quirófano trabajando mientras todos estamos acá. Gracias, Catherine. Catherine, did you click the translation?
Most of the fun.
Great. Did you click the translation icon? Ok, Álvaro.
Ok. Seguimos entonces. Tengo otra pregunta que también se ha repetido varias veces, y es si alguna de las personas que hacen lateralización sacan el punto en algún momento como procedimiento de rutina.
Creo que fue contestada esa pregunta.
Doctor Sarrabar.
May I ask a question?
Yes.
Or a suggestion? I
Yes,
have had this conversation with Mariella. I think that the procedure that she presented is fantastic. My only thing that I would like, because I know there are 842 people are listening to this conversation, I do feel this is a very delicate surgery, and we are operating on very small children. So I would really recommend for everyone to practice on this before you do this procedure as the first time. And my second suggestion is, I would also recommend for everyone to think about using non-absorbable sutures such as Prolene instead of Prolene, such as PDS. I do feel if you use a PDS, it provides you several weeks of retention and it will help it heal. I always get worried about using non-absorbable sutures on any part of the airway because, as you know, these children are going to grow up to become adults, and after 20 years, 30 years, some granulation tissue and things can affect it if we even leave small pieces of that. So just something to think about.
Yes, we got already this kind of conversation in the past. I know your position about that, but what give us the Prolene is the chance to remove. We don't feel comfortable to remove a PDS after 4 or 6 weeks. And because that was an experimental procedure in this kind of patients, we are talking about a wide range of age with different comorbidity, with different history of larynx surgery previously. So we did in a laryngeal cancer of a 2-year-old kid. We did right after after radiotherapy, we didn't know how the vocal process and the arytenoid position, final position, will end up, and we were not sure that we will take a risk of maybe impair in some way the swallowing, or decrease the quality of the voice in a bad way. So we want a backup, a parachute, and the chance to remove. We think, oh my God, we create a much too large space. So that's what we experience, and never happened that we removed the stitch and we had to redo the surgery again. That's so far never happened. At the same time, the longest follow-up that we have now is a bit more than 2 years, and we didn't experience any granulation for the few patients where we left the stitch.
Ok, Álvaro. Gracias.
Okay. Vamos a permitir una pregunta con micrófono. El doctor Aldasher Ali puede hacernos su pregunta.
Está sin micrófono. Yo le voy a activar el micrófono.
Okay, it's done. Ok, otra pregunta, Álvaro, y después podemos seguir con el doctor Aldasher Ali.
Ok, tenemos, en la audiencia tenemos varios y varias fonoaudiólogos y tienen la misma duda, y es cuál es el efecto sobre la alimentación y sobre el potencial riesgo de aspiración que pueden tener estos pacientes después de hacer o una lateralización o una colocación de un injerto endoscópico posterior.
Perfecto. Quizás le podríamos preguntar a Catherine esa pregunta. Doctora Hart, ¿cuál es el riesgo de aspiración de los pacientes que son sometidos a un injerto posterior, una lateralización o un AP cryosplit?
So any of the procedures that enlarge the posterior glottis all come with a risk of aspiration, and the extent of aspiration is going to depend on how aggressively you expand that space. But that is absolutely a concern with any of these procedures, and one of the things that as a surgeon you have to be cognizant of, and it's always trying to balance all of the functions of the airway, the swallowing, the breathing, and the talking, and you sometimes can't get all three of them perfect.
Gracias. Álvaro, ¿tenemos alguna otra pregunta del chat? Estamos 10 minutos atrasados, pero los vamos a recuperar.
No tenemos muchas más preguntas. Tenemos otra pregunta, que es si los panelistas tienen alguna experiencia en el uso de la electromiografía laringea en pacientes pediátricos, y especialmente en estos pacientes que son tan pequeñitos, que tienen la parálisis congénita.
¿Quién puede responder el estudio sobre cómo evaluar la denervación laríngea?
Doctor de Alarcón probablemente es el que tiene más experiencia.
Sandro, Mike, feel free, please, to make any comments.
Yeah, so EMG in asleep children is interesting. I'll put it that way. It really is based on, you have to have a good team built around doing it. We've done some here. It's very hit or miss because placing the electrodes can be quite fiddly, and having the right ones and having them seat properly. You can sometimes, especially in some of these smaller infants, as you're doing it, you can get some bleeding and create some issues in terms of swelling when you're putting in a needle in both vocal folds, the PCA, the interarytenoid. So it's not without you know, having its risk too, like in these smaller infants where you can actually push them over the edge and then you're forced to do something acutely for their airway. And then I think the results of what you get, because you have to put in the electrodes and then you have to get the child into a respiratory phase where they're light enough that you get some aspect of voluntary movement. And I would say that's sometimes the biggest struggle with doing it. So I think people are starting to do more EMG, trying to figure out where this fits, you know, and thinking about it as well is that if you look in the adult literature, they would really never do this in a sleep patient. They would always do it in an awake patient to get voluntary movement. And so I think there's always questions about what does it really mean when you're doing this under a general anesthesia. And that's something that I always think about when we do it. I would say I have a love-hate relationship with EMG, which is when it looks pretty decent, it's helpful. When you can't get them in the right plane, you don't know what to make of it.
Muchas gracias. Diego Preciado, por favor.
I'll just follow up on what Sandro, I just want to comment on your comments because I completely agree. And I would just make the comment that if you're going to start doing laryngeal EMG, doing infants is really not the place to start. Beyond what you already mentioned, I agree completely that spontaneous ventilation anesthesia in the newborn can be quite challenging to achieve, and that window is in general much harder. And many of these kids with it, I don't think we understand idiopathic bilateral vocal cord paralysis enough to really get at the fundamental neurophysiology of the condition. And so the interpretation of laryngeal EMG in the idiopathic bilateral cord paralysis child is quite difficult at this point, because as you know, these often are laryngeal dyskinesias where there may be nerve activity and it's just hard to interpret. So I think that I agree with what you said. We don't do laryngeal EMG in infants. We will do laryngeal EMG in older patients. But I'll just make that comment.
Perfecto. Muchas gracias.
Doctor Jennings.
Dr. Jennings.
Sí, y después vamos a ir al café, creo, Álvaro, o una pregunta más del panel.
Una pregunta más y vamos al café.
Okay.
Russell, please.
I just have a question on the technique of doing laryngeal EMGs in infants. Could you, Alessandro, you were talking about inserting probes. I presume those are transoral, the bipolar probes that are put in the Prass electrodes, as opposed to translaryngeal probes?
Correct. They're usually transoral. I've actually moved to using, they have some really, really thin, like micro needles that you can use that work well, that aren't super bulky, but still in the context of when you're trying to do that in an infant, like as Diego mentioned, it is not super fun. Yeah, like, and they are super fiddly, right? Because you try to get them placed and they dislodge very easily in infants. So I can say that I've done it. Have I been super happy about doing it? Absolutely not. And so I think it's one of those places where, as Diego mentioned, we're still trying to figure out what's the neurophysiology of what that really looks like. And I know in the chat, Hamdi El Hakim, who's done some work in this area before in terms of doing EMG and probably has a pretty extensive experience with it as well. And I think they're just difficult kids to really sort out, and then sorting out what that really means is probably the hardest part. But I think if you're going to consider it, you really need to have a specialized team that's already, as Diego mentioned, done it in older kids. And, you have to have someone who, like, we're kind of like the technicians for this piece. We place the electrodes and you have to have a neurophysiologist read it. So that means you have to, whether it's a neurologist or for us, it's a PM&R physician. And then you add in, like, you have to have great anesthesia, right? You have to have someone who can sort of get them in that right zone and, put them back asleep if you need to, if they try to come off the table because they're suspended, right? So that's why I say, like, it's one of my least favorite things to do.
Oh, I didn't realize you were doing it in suspension. I can get prepared when I can talk about it. We now do 2-channel recurrent laryngeal nerve monitoring on all our kids down to 900 grams without using those probes. We sort of gave up on the Prass electrodes and the translaryngeal probes. They just suck. They keep falling out and they're hard. But if there's any interest, I can show you how we're doing our bilateral recurrent laryngeal nerve monitoring. It's not quite EMGs, and we don't separate adductors from abductors, but at least it's a tool going in the right direction.
So I think if you're talking about the ET tube wrapped like monitoring for when you're, that's really not going to do the same thing as EMG. It's nowhere in the same ballpark. So it's super useful for what you mentioned is when you're doing, you know, procedures that you think are going to put the recurrence at risk. It can be very, very helpful. But in cases of trying to actually do true, like understanding, like, it, you know, is there innervation and what kind of innervation, meaning is it denervated? Is it reinnervating? Like you really need to pass an electrode into the muscle to really get that done. And as you mentioned, like super fiddly and not fun.
And let me just probe a little bit more because this is an area of interest. Do you separate the adductors from the abductors when you do these EMGs?
Yeah, so you have to selectively do each muscle, and that's the part that can be also be painful.
And is there any attempt, I've never heard of this, any attempt to monitor or assess sensation, which may have a huge component with aspiration?
Usually we do that through like some other tests. So that would be a FEES where you can get a sense of what their sensory aspect is with swallowing. I think what's hard is sometimes with these infants when they're, you know, you may not be able to get them to a place where they're stable enough where you can do a, you know, FEES exam on them awake. But that's probably one of your best tests to be able to see and assess sensation. And sometimes you can do a really gross assessment of sensation with a flex scope, which is, you know, just bluntly hitting like different parts of the larynx. There used to be actually a device that was developed by KLMetrics, which became Pentax, that allow you to do air puffing at the larynx to really test what pressure sensation you had in the larynx. They don't make that device anymore. I think we still have it because we bought it, you know, 20 years ago, but it doesn't work very well. So most of the time you have to do sort of a either assessment as you're doing the FEES or use your scope as your sort of blunt instrument to see if they feel it. If they can't feel a scope hitting certain parts of the larynx, then they're insensate. And then you're having different conversations. Like you're going tracheostomy more likely because they're gonna be super high risk for aspiration.
So let me just my final probing question is: what is the significance of vocal cord motor function closure with swallowing as opposed to sensation to prevent aspiration?
Okay, después de esta pregunta, vamos a ir al chat. Alessandro, ¿quieres contestar un poco breve, por favor?
Sure. They both play an important role in the role of protection of swallowing, right? So you have to have sensation. So if you have poor sensation, you're just going to be more at risk for events. And then you have to have good muscular control for closure, right? The closure piece is the part that does the protection part. If you have one or the, like, so when we do some of these open procedures or endoscopic where we widen, like we kind of get rid of some of that ability to fully close, but they oftentimes, those kids have good sensation, so they compensate. If you have, like you have poor sensation and then you make them bigger, that's when they get into trouble.
Es muy interesante y gracias Russell por las preguntas y comentarios porque podemos ver cómo muchos de ustedes podríamos quizás estar un día completo en un panel de problemas de vía aérea y quizás tal vez un día completo
y no será
hablando
suficiente.
de parálisis de cuerdas vocales y quizás un día completo hablando de inervación de la laringe. Es un tema apasionante. Álvaro, ¿alguna pregunta? Tenemos que ir al coffee.
Sí, ok. Vamos con la última pregunta, que también es una pregunta que se ha repetido, una pregunta que nos hace la doctora Pilar Gajardo de Chile y además el doctor Kishore Sandhu de Suiza. Y ellos quieren saber qué experiencia tienen los panelistas sobre la reinervación laringea y si es que tienen alguna experiencia, desde qué edad recomiendan que se pueda hacer la cirugía de reinervación laringea.
Diego, escuché a Pamela Mood hacer una conferencia al respecto en Washington. ¿Puedes contestar?
Sí, nosotros utilizamos la reinervación, pero más para los parálisis unilaterales y partiendo de la edad de, creo que el más joven que ha hecho en nuestro centro se ha hecho es partiendo de los 3-4 años de edad. Para la parálisis bilateral idiopática, no conozco de recién nacidos que hayan tenido reinervación bilateral, aunque hay un trabajo reciente de Marshall Smith interesante, provocador, digamos, con mucha innovación de reinervación bilateral como para manejar la parálisis bilateral. Pero los resultados a largo plazo en términos de resolver la necesidad de una traqueotomía son muy difíciles de interpretar y difíciles de saber si tiene éxito en este tipo de obstrucción. Así que la reinervación se hace más como para restablecer el tono muscular, mejorar la voz en los pacientes que tienen parálisis unilateral primordialmente. Esa es mi experiencia. No tenemos experiencia de reinervación bilateral. No sé si Sandro tenga experiencia con inervación bilateral. Sé que son pocos pacientes que se han operado en el mundo.
So with reinnervation, bilateral reinnervation, so Marshall Smith is probably the one in the US who has the most experience doing it. It is not a trivial operation. It is an 8 to 10 hour operation. And, you know, it's interesting because in his paper, he suggests you can use it for patients with bilateral, you know, congenital paralysis. But in my conversations with him, he suggested that those are the least good candidates. The best candidates are typically iatrogenic injury. So patients who had normal function and then had like a, you know, total thyroid and have bilateral paralysis post, or they've had a thoracic procedure and you knew pre they were normal and post they have bilateral paralysis. We do have one patient here that we're considering doing that, but, you know, again, it's that piece of, it is not a trivial operation because you're hooking up to a rootlet of the phrenic, doing a cable graft that you're embedding into the PCA bilaterally. So that's not, and it's all done like submucosally. So that's not a, you know, it's not one of those operations you should, that I think is viable yet. I think there's promise with it. And it's going to take some people pioneering and learning how to do it. And I think that needs to stay in centralized centers because it's I think a very difficult operation to do, and you really don't want to push that as like everybody should be doing and doing like one in a year. Like that's something you need to be doing multiples of a year.
Muchas gracias, muy interesante. Diego, un último comentario.
Dr. Rabar wants to make a comment.
Diego. Ok, entonces...
Pato, Reza quiere hacer un comentario. Dr. Rabar quiere hacer un comentario.
Please.
I know, I'm sorry, I know we are running behind, but I think if you give me 2 minutes, I really think it's important to state this. There are 14 of us on the screen who are wearing eyeglasses. The reason, now we are 13, Patricio. So the reason we are wearing eyeglasses, because when they do our eye exam, they can tell us our vision is 20/30, 20/40, 20/50, and they can correct it to 20/20. Our fund of knowledge for vocal cord paralysis is either it moves, it doesn't move, or it maybe moves. We are not there yet. The only time we can have a very good answers to questions that Rusty raised, which are extremely important questions, is if we can actually have a metric system for diagnosis of vocal cord paralysis that is precise. to the same way that we measure hearing or we measure eye exam. So it is very important to state this. So when we come up with a treatment plan for children, it is exactly like giving eyeglass to a patient with not knowing exactly what precise deficiency they have on their vision. So I just want to make that statement. So for the new generation, the next step is to come up with a precise measurement. Right now, as Alexander knows, diagnosing with looking at abductions, at each nerves and doing EMGs, it is still not there yet. So I think that may be worth stating. And I'm sorry to take time from the coffee break.
Muy interesante lo que acabas de decir, Reza. Muchas gracias por el comentario. Diana, Álvaro, ¿quieren agregar algo? Vamos a ir a la encuesta.
Vamos a ir a la encuesta, vamos a relanzar la votación, a ver si cambió en algo nuestro
Momento,
punto de vista.
estoy compartiendo pantalla, ¿está bien? ¿O no?
¿Puedes compartirla?
No, está bien.
¿Estaba compartiendo?
No, estamos en el panel.
No estabas compartiendo.
Ah, perdón. Ahora voy a compartir la pantalla entonces. Dame un segundo. Aquí estamos.
Mientras terminan de contestar.
Queremos hacer la misma encuesta que hicimos anteriormente. Diana, ¿quieres decir algo?
No, que nuestra audiencia está muy activa y también estamos en vivo en Facebook.
Ok, nuestro desafío ahora es mantener a la audiencia con nosotros. Hay 800 conectados, más en Facebook Live, y la segunda parte de este evento va a durar más o menos 1 hora y 30. Es muy entretenida y ya llevamos de conferencia cerca de 2 horas y media. Hagamos la pregunta nuevamente, Diana, ¿te parece? Si ha cambiado en algo la opinión de la asistencia respecto del recién nacido que mostrábamos con parálisis bilateral de cuerdas vocales. ¿Harían una traqueostomía, una endoscopía, algún procedimiento endoscópico o alguna cirugía abierta? Por favor, respondan una sola opción.
Me anticipé un poquito, ya han contestado 350 participantes y vamos a compartir los resultados. 72% traqueostomía, 30% un tratamiento endoscópico y cirugía abierta, un mínimo porcentaje.
Se mantiene la tendencia traqueostomía sobre un 70%, y la opción endoscópica me parece muy interesante que la audiencia esté con el entusiasmo de ofrecer al menos a 1 de cada 3 pacientes una alternativa endoscópica. Gracias, Diana. Creo que podemos ahora ir a nuestro tiempo de coffee, Zoom Coffee. Disfruten de un café. En 5 a 10 minutos nos volvemos a reunir. Les recuerdo que nuestro sponsor que nos acompaña y que nos apoya permanentemente es Clínica Yayo, de Colombia, y también Tracoe. Vamos a colocar un video de Tracoe durante estos 5 a 10 minutos y nos reunimos nuevamente para seguir con la segunda parte del evento.
Bueno, en la siguiente sesión vamos a hablar de estenosis de tráquea posintubación, de cómo se trabaja en equipo sobre los pacientes con patología de vía aérea y cómo estamos en tiempos de COVID manejando nuestros centros de vía aérea. Así que los esperamos de regreso.
Por favor, en 5 minutos nos volvemos a reunir. Ya voy a compartir, Diana, el video. Un momento.
Gracias, Pato.
¿Estás viendo mi pantalla o no todavía?
No, compartida no.
¿No?
No, no, Pato, no se ve.
Ok, ya la vamos a ver. ¿Ahora?
Perfecto.
The Airway's balloon catheter is designed specifically for the unique challenges of dilating airway strictures. An effective airway dilation procedure must be completed safely and expediently. However, slippage of the balloon catheter as it inflates is a common problem, resulting in extended surgical time or an abandoned case. The Airway's balloon addresses this issue in a safe, timely manner. Upon initial inflation, two hubs appear distally and proximally on the balloon. This locks the balloon in place over the stricture, greatly reducing the possibility of watermelon seeding. Additionally, there are only two inflation pressures on the Aries balloon. Full color-coordinated lure locks correspond to the proper atmospheric pressure setting on the inflation device gauge. This is a simple and responsive device for relieving airway strictures. The Aries BDC comes in a large array of sizes to meet both pediatric and adult surgical needs. Conveniently. However, slippage of the balloon catheter as it inflates is a common problem, resulting in extended surgical time or an abandoned case. The Aries balloon addresses this issue in a safe, timely manner. Upon initial inflation, two hubs appear distally and proximally on the balloon. This locks the balloon in place over the stricture, greatly reducing the possibility of watermelon seeding. Additionally, there are only two inflation pressures on the Aries balloon. Full color-coordinated lure locks correspond to the proper atmospheric pressure setting on the inflation device gauge. This is a simple and responsive device for relieving airway strictures. The Aries BDC comes in a large array of sizes to meet both pediatric and adult surgical needs. Contact your Bryan Medical representative today.
For incisions in a cross, there's no truth in it, but this is our concept. So how we do it, it was first this do 4 incisions in a cross. We also do it, we are in Stuttgart, so we do a Mercedes star incision as well. Again, I used scissors, which works very nicely. The scar is a little bit stiff, but it works. You can again use some knives, some sickle knife or one-way knives as well. And I don't know if it's necessary at all, but we do it that we know where the fractures are. So now again on that direction and again in that direction. Yeah, and well, I forgot one thing to figure out, to palpate the stenosis, and it's interesting. It's very soft, so it's more like edema. So we will see what we can do with a dilatation. Okay, now I show you the brand new, or in the German market, brand new Aries system. Perhaps we can go back on the macroscopic view. So this is the balloon. It's covered, of course, so we can take that off. And now you can bring it in again like all the other balloons. And there is a guide wire inside. And of course, the inflation device. And it's very simple. And the condition is quite nice. It's a little bit bent on the one side. And it's soft, but still stable. So it's very easy to place. Then we switch on the endoscopic view again. So We always do it under endoscopic view to place the balloon. The good thing is that with an endoscopic view, you can place the balloon properly. With a microscopic view, so I try to show you, you can always check where is the end, where is the beginning, can you touch the whole stenosis, can you touch only a part? And especially this watermelon effect is if you are not centering the stenosis in the balloon, it can happen that the balloon drops in that direction or in the other direction. Well, not unfortunately, but I cannot show it with this balloon because this balloon cannot move that fast. It is a little bit shaped like a bone. So this cannot happen that the balloon moves distally or upwards. So now we remove the guide wire. So I would say I placed the balloon absolutely in the middle of my pathology. Now we connect the deflation device. You know what I mean. And now we inflate the balloon. And it's very simple. The system, this system is made for 10 atmospheres. And I'll try to show you if I can imagine. Sometimes we are lucky, you can place the scope directly in the balloon and see the dilatation. I have a meter balloon. As you remember, it's system. Fortunately, I have the news, so I shortly have to place a tube, but we can already see that we have a nice enlargement, which is not too bloody.
Okay, Diana? Is Diana there? Diana, la pantalla la puedes compartir.
Gracias, Pato. Vamos retomando. ¿Puedes parar tu video?
Sí.
Gracias.
Sorry. Okay. So after this presentation, with the map, we will follow with the conference.
Bueno, vamos retomando la actividad. Increíble el trabajo de los ingenieros biomédicos de Clínica Chayo, un soporte permanente en mi actividad del día a día. El trabajo de ellos, lo que están pudiendo disfrutar en este momento. Somos 54 países de casi todos los continentes. Y queremos invitarlos.
I will show that. Okay, great.
Bueno, queremos invitarlos desde ya a la segunda versión de este webinar en el mes de julio. Recibirán información en los próximos días. Estamos trabajando para ustedes. Adelante, Pato.
Gracias, Diana. Creo que ya podemos ir comenzando, ¿les parece?
Sí, yo creo, sí.
Sí, creo que ahí estamos conectados. Diana, quiero felicitar también, te quiero felicitar a ti por haber organizado, haber tenido la iniciativa de organizar este evento. Nos entusiasmaste a nosotros, y cuando digo nosotros, incluyo a mucha gente. Así es que gracias por tu trabajo y todavía queda bastante, nos queda 1 hora y media y esperamos que todos nuestros asistentes estén entretenidos y al final van a tener acceso al chat por video y por audio. Creo que ya podemos comenzar. Diana, ¿quieres anunciar nuevamente? Hay muchos tópicos que no van a ser tratados hoy. Los tiempos son complicados en un webinar. Este es un webinar bastante largo, de 3 horas y media, y hemos por eso programado una actividad bien interactiva. Y hay muchos tópicos que quisiéramos tratar en la segunda versión de este evento, que va a ser realizado muy pronto. Diana, ¿quieres decir algo?
En julio estamos trabajando en el programa y ya tenemos varios conferencistas confirmados. Así que vamos a estar todos trabajando por nuestro segundo webinar.
Perfecto. Entonces podemos continuar, ¿les parece? Álvaro, nuestros panelistas están conectados.
Estamos ok.
Están todos ok, acá los veo. Nuestro amigo Aldasher, Ali, no
No pudimos conectarlo, al final yo creo que ya los podemos conectar.
Ok, entonces vamos a continuar con nuestro segunda sesión de casos clínicos. Vamos a presentar un caso. Este es un panel de estenosis traqueal post-intubación. Vamos a referirnos específicamente a la estenosis traqueal. No vamos a abordar la estenosis subglótica. Eso quedará para el próximo evento. Nuestros panelistas, Dr. Mike Rudder de Cincinnati, siempre acompañándonos. Mike ha sido un soporte muy importante para nuestro centro y nuestros centros desde hace muchos años. Russell Jennings también nos acompaña desde Boston. Muchas gracias, Russell, por estar hoy con nosotros. Russell es un soporte también permanente de nuestros equipos. Él ha desarrollado un centro de mucho interés al cual va a hacer referencia más adelante. Michele Torres desde Italia, que siempre nos acompaña. Jaime Penchina desde México y Gastón Beliá desde Argentina. Diana, te quiero dar la palabra.
Gracias, Pato. Antes de continuar con el caso clínico, quiero explicarles, dado que tenemos un diverso público, que existe una diferencia entre la estenosis subglótica y la estenosis de tráquea, que se pueden confundir cuando no están familiarizados con el tema. La subglótica es alta a nivel de cricoides y la de tráquea es más distal, es ya en los anillos de la tráquea. Y hay dos mecanismos por los cuales se genera el daño. El primero puede ser por la lesión que genera el contacto del extremo distal del tubo, donde usualmente la lesión es en la pared posterior, y el más frecuente es la lesión causada por el balón, porque cuando se utilizan presiones elevadas, mayor de 18 centímetros de agua, hay hipoperfusión tisular, se genera una inflamación, podemos pasar la diapositiva, en la pared, una lesión profunda que al cicatrizar genera la estenosis. Adelante, Pato, con el caso clínico.
Quiero compartir un caso clínico reciente del mes de abril de este año. Es un paciente de 5 años que sufre un accidente mientras estaba jugando en una plaza. Producto del accidente, sufre una fractura de la mandíbula, es ingresado al servicio de urgencia y es operado de la mandíbula al día siguiente. La cirugía mandibular fue una cirugía larga y los cirujanos decidieron mantener al paciente intubado por 5 días. La lesión mandibular mejoró en el tiempo, sin embargo, después, algunos días después de la extubación, que fue de 7 días, el paciente comienza con estridor. Esto fue este año, en el año 2020. Fue derivado a nuestro centro en Santiago de Chile y el paciente traía este estudio tomográfico de tórax y de cuello, donde se puede apreciar claramente que existe una lesión, una estenosis del lumen traqueal a nivel de la tráquea cervical. La tráquea intratorácica se aprecia sana, la tráquea hacia arriba, cerca de la laringe, está sana, sin embargo hay una estenosis un poco más abajo. Este paciente ingresa a nuestro centro en abril de este año, 2 meses, como dice acá arriba, 2 meses después de ese evento del accidente y de la intubación, y nosotros recibimos a un paciente en buen estado general, con un estridor moderado, y decidimos hacer un estudio endoscópico que quiero compartir con ustedes. No hay lesiones laringeas, el espacio subglótico es normal, la mucosa es normal. Sin embargo, existe una estenosis que comienza más o menos a nivel del segundo o tercer anillo traqueal. El estudio se está realizando con una óptica 4 milímetros 0 grados, 4 milímetros 0 grados. Pasa la óptica por la zona estenótica con algo de dificultad. Podríamos estimar que el lumen en la zona estrecha es más o menos 3,5 milímetros, si pudiéramos establecer una relación con la óptica, que mide 4 milímetros de diámetro. Y ustedes pueden ver que la tráquea distal la tráquea distal es bastante sana. Hay 1, 2, 3, 4, 5, 6, 7, 8 anillos, es decir, la estenosis alcanza el anillo 7 y compromete más o menos un anillo, 2, 3, 4 anillos proximales. Quizás el primer anillo traqueal se encuentra sano. Entonces, en resumen, se trata de un paciente. ¿Me puedes dar el video, Diana, si estimas? En resumen, se trata de un paciente de 5 años con una estenosis traqueal post-intubación, 2 meses después del accidente. La lesión compromete 4 anillos aproximadamente. Es una lesión bastante importante. El paciente tiene un estridor más bien moderado que incrementa con el ejercicio. Y bueno, reitero, la endoscopía fue realizada 2 meses después. Entonces, quisiera preguntarle a la audiencia, a nuestros asistentes, ¿qué harían con este paciente que tiene una estenosis traqueal? ¿Cuál sería la conducta o qué podrían sugerir ustedes si alguien les presenta un paciente con estas características? ¿Dilatarían esta lesión considerando que la lesión tiene cerca de 2 meses? ¿O irían definitivamente a una cirugía? Por favor, elijan una sola opción.
Bueno, vamos con nuestra votación. ¿La están viendo en pantalla? En el chat nos contestan. Súper activo está.
Y veo que hay mucha actividad, 390, 400. A ver si llegamos a los 500, 450 asistentes respondiendo. Han respondido más que en la patología cordal, claro, porque esto es un tema quizás muy transversal a toda nuestra audiencia, donde participan cirujanos torácicos, cirujanos pediatras, otorrinolaringólogos, cirujanos de cabeza y cuello, cirujanos torácicos adultos, hay algunos también.
Y te comento que hay mucha audiencia de especialidades clínicas que son trascendentales en el manejo de estos niños. Están inscritos pediatras, neumólogos pediatras, radiólogos, anestesiólogos, cirujanos cardiovasculares,
sí,
enfermería.
Muchos pulmonólogos, broncopulmonares pediátricos que están conectados hoy día, de toda Latinoamérica.
De votación, ¿te parece?
Me parece. Creo que podemos seguir.
Ya, estamos viendo los resultados. El 78% le haría una dilatación endoscópica y el 22% cirugía.
Perfecto. Quiero presentar a nuestros panelistas, el doctor Russell Jennings, Michael Rutter de Cincinnati, Jaime Penchina de México, Gastón Beliá, Michele Torre de Italia. Ya los había presentado. Nuevamente quiero dar la palabra al panel. Quizás comenzamos preguntándole a el doctor Jennings. Está el doctor Jennings acá con nosotros, ¿cierto?
I am right here.
Yeah.
This is an interesting case.
I have a question for you.
The stenosis of the trachea on the single scan we saw appears to be circumferential. There's a posterior tracheal anterior spinal mass, and I presume the esophagus is not involved, but the good news is this is really a cervical lesion. It's up in the neck. It's above the sternal notch. So not only would I do a thorough evaluation of the esophagus and obviously the nerves to make sure everything's okay. I think the first shot at trying to get a dilation with steroids would be a reasonable shot based on the child's health. We've also had a little bit of luck in really tough strictures which have failed steroids. And I don't advise this, and to just keep a secret just between us so nobody share this, which is I will sometimes inject mitomycin into very hard strictures like this, only on the cartilage side, and then dilate that. And we've had some pretty good success with that.
Russell, nosotros en estos pacientes muchas veces no hacemos estudios de imágenes. Creemos que la endoscopía es suficiente para definir una estrategia terapéutica y un pronóstico. Sin embargo, este paciente llegó a nuestro centro con una tomografía y muchos de nuestros pacientes finalmente la tienen con un estudio radiológico. ¿Qué importancia le darías tú al estudio radiológico tomográfico en un paciente con una estenosis traqueal? ¿Crees que es de utilidad? ¿Podríamos encontrar algo un hallazgo que nos podría ayudar en nuestras decisiones terapéuticas? Entiendo que para ti tiene mucha utilidad este examen y también para evaluar el esófago.
Thanks, Patricia, for that. It's a great question. And I think it really, the question of imaging and assessment of a child prior to an intervention really depends on local resources and the strategies that you tend to employ. As Pato knows, all I do is extremely complicated reconstructive surgery. Every child gets a complete evaluation, including a high resolution CT angiogram, including what we call an Art of Adamkiewicz study. So yeah, it helps. Does it help every time? No, sometimes you say, I wasted the radiation. But the involvement in this case, I'm a little concerned about that posterior mass behind the trachea. That's right where the esophagus could be. You need to know that if you're going to do any procedures, including a dilation, because if you tear that posterior wall and you get into the esophagus, it changes the operation a little bit into a fistula, which is, as Pato knows, not the world's end. You just go fix it, but you do need to know what you're facing.
Ok, muchas gracias, Russell. Quisiera darle la palabra al doctor Michael Rutter, de Cincinnati. Mike, ¿estás ahí, cierto? Sí, Mike.
Yes.
Disculpa.
Yes.
Estoy con el video encendido. Mike, ¿cuál sería entonces tus recomendaciones para las estenosis traqueales como esta? Es una estenosis más bien en una etapa ya fibrosa, cicatricial. ¿Haces alguna diferencia si el paciente consulta en etapa aguda, precozmente o tardíamente? Go ahead.
Generally speaking, what I would do would be to firstly balloon dilate. It will immediately give you an improvement in the airway, and then I would usually bring the child back 7 to 10 days later, steroid inject, divide any scar bands that are still present, balloon dilate again, and be prepared to do this 3 or 4 times. I would typically expect that would be adequate long-term in 8 out of 10 kids. And if it doesn't work, a cervical slide would be, it's a fun operation. But again, even though I thoroughly enjoy doing that operation, most of these I can fix endoscopically. And I'd always try that first and save the open procedure for the failures.
Gracias, Mike. Quisiera darle la palabra al doctor Jaime Penchina. Jaime, ¿estás con nosotros?
Sí, Pato, ¿me escuchan
Jaime,
bien?
¿qué haces tú con un paciente? Ustedes tienen mucha experiencia, México tiene una población que tú la podrás recordar, deben tener mucha derivación. Nosotros, en un país de 16 millones de habitantes, 17, evaluamos más o menos 2 pacientes como estos al año. 1 cada 10 estenosis subglótica. Tú debes tener mucha experiencia con casos que llegan probablemente tardíamente.
Sí, Pato, espero me escuchen bien. Gracias por la invitación. La experiencia en México, como tú dices, es bastante amplia porque tenemos muchos pacientes, somos centro de referencia. Y este caso en particular a mí me llama mucho la atención porque endoscópicamente se ve como una estenosis no simple, sino compleja. Hay aspectos endoscópicos que me hacen suponer que el daño traqueal es importante. Y para mí este paciente es quirúrgico y les voy a explicar por qué. Es un paciente que no tiene cirugía previa cervical. Es un paciente que tiene claramente la estenosis a nivel cervical. Y mi pensar en hacer cirugía en este tipo de casos es que la resección es el abordaje no es difícil, la resección es limitada y haciendo una buena anastomosis yo le voy a ofrecer la ventaja que si se hace la cirugía bien con un cirujano con experiencia, el índice de éxito es prácticamente el 100% en un solo procedimiento, quedando una tráquea perfecta, sana. Ese es mi pensar, Pato. Y basado en muchos años de hacerlo, este niño si me llega ahorita al hospital, sí está un poco con dificultad respiratoria, puedo introducir algún tubo, o sea, hacer una dilación, pero este paciente para mí, en mi centro, es quirúrgico.
Gracias. Michele Torre nos acompaña desde Génova, Italia. Michele, ¿cuál es tu recomendación respecto de este caso? Respecto del estudio y respecto del tratamiento, ¿ustedes disponen de balones para dilatación? ¿No está Michele? Gastón Belia, ¿podrás contestar la pregunta? Gastón Belia, desde Buenos Aires, Argentina.
Pato, ahí está Michele.
Está Michele.
Ok.
Sorry, I was mute. Hello to everybody. Thank you, Pato. Thank you, Diana. And for evaluation, I agree that endoscopy is the gold standard. We use a CT scan when the stenosis is very difficult to pass with an endoscope, so we can evaluate better the length of the stenosis, but or if there are a suspect of some associated anomaly, vascular anomaly, but otherwise endoscopy for us is enough. In this specific case, and this is quite frequent when there is the tracheal stenosis, the cartilage can be affected. In my view, the stenosis is, the tracheal stenosis is different from subglottic stenosis because the scar component is maybe limited, and a big part of the stenosis is due to the collapse of the cartilages. Cartilages can be deformed, can be absorbed by the inflammatory process or the infection. So in my view, this is, as Jaime suggested, a surgical case, because for to do a resection, cervical resection, is quite simple, and without long intubation, maybe the patient can be extubated the bed or the day after, and I think we can obtain a good result. Obviously, if I evaluate this patient and I'm not prepared for the surgery because it was only an evaluation session, we can decide to dilate the patient with a balloon and to see how it works. If maybe it works well, we can reconsider surgery. But I'm concerned about the cartilage framework, and I don't think the balloon can have the same success as the surgery.
Gracias, Michele. Quisiera darle la palabra a Gastón Beliá, de Buenos Aires, Argentina. Gastón es cirujano pediatra. Gastón, ¿algún comentario de este caso? ¿Tú harías dilataciones para comenzar? ¿Lo operarías el mismo día que haces el diagnóstico, si el paciente está en buenas condiciones? ¿Qué nos puedes decir al respecto?
Bueno, muchas gracias Diana y Patricio por la invitación. Es un honor para nosotros estar en este panel. Sabemos del trabajo que han hecho para que esto esté saliendo como está saliendo, así que los felicito. Con respecto al caso, es un caso interesante, no menos frecuente. Esto es un paciente que se da frecuentemente una estenosis traqueal luego de una intubación de pocos días en un paciente previamente sano, que no ha tenido, digamos, afectación del estado general, acidosis, inflamación sistémica y demás. O sea que no es infrecuente este paciente, lo hemos tenido. Siempre que recibimos una derivación, nosotros hacemos la endoscopía inicial para evaluar, no confiamos o no nos guiamos de los estudios previos. Por lo general no hacemos una tomografía cuando estamos sospechando una lesión a esta altura y a este nivel. Pero ya en la tomografía, si la tenemos, podemos ver que impresiona que la pared de la tráquea, hay un engrosamiento de la pared. Si uno ve en esas zonas, es muy distinto a los cartílagos en la parte distal. Uno no puede asegurar de que eso sea un compromiso del cartílago, pero ve que la inflamación sobrepasa a la mucosa. Así que es un dato a tener en cuenta. Y si vemos en la endoscopía, para nosotros esa endoscopía tiene dos, creo, datos fundamentales. Primero, la característica de la lesión, que es concéntrica. Es una lesión que siempre, si no pasamos con la óptica, vamos a dilatar para poder ver la tráquea distal. Pero bueno, este paciente se pudo pasar con la óptica de 4 milímetros y se ve la extensión, que tiene aproximadamente 4 centímetros. Y algo para nosotros fundamental es que está circunscripta. Es decir, los anillos proximales y la mucosa proximal está bien, y la mucosa distal, como se ve ahora, también está bien. Es decir, que es una lesión que tiene 2 meses de evolución y sabemos dónde comienza y sabemos dónde termina. Vemos tráquea sana o tejido sano proximal y vemos tejido sano distal. Así que en este caso nosotros no tenemos buena evolución con las dilataciones, con este tipo de estenosis. Para nuestro grupo este tipo de lesión es quirúrgica y lo que hacemos es dilatamos en esta endoscopía de inspección, ponemos diprogenta, avisamos a los familiares, le decimos cuál es la conducta, preparamos terapia, preparamos sangre y probablemente en 10 días estamos operándolo. Un último comentario. Si nosotros no tuviéramos la lesión circunscripta, es decir, que la mucosa proximal está dañada y no sabemos dónde puede comenzar la parte sana o la parte distal, o sea que es una lesión muy larga, quizás sí ahí dilatamos y vamos viendo y le vamos dando tiempo a que esa lesión se circunscriba, porque en nuestra experiencia no nos ha ido muy bien con las dilataciones, no hemos tenido buen resultado, y en esos pacientes que tenemos esas lesiones más extensas y menos circunscriptas, terminamos operándolo después de 3 o 4 dilataciones, con una lesión obviamente menor y con menos resección traqueal.
Ok, nosotros, gracias Gastón, muy interesante tus comentarios y has hecho un análisis muy claro de todo. Ya has comentado algo de la tomografía que me pareció muy interesante. Quizás la tomografía nos sirve de verdad. Tú dijiste que no la hacían mucho, nosotros tampoco, pero por lo mismo que has dicho, creo que la voy a empezar a hacer un poco más. Es muy claro cómo se ve el compromiso de la mucosa y quizás sea un índice para decidir dilataciones o resección inmediata, no lo sé. Quiero darle la palabra a Mike, nuevamente. Mike, please. Mike, quiero comentar que nosotros inicialmente comenzamos a dilatar a este paciente. Con dilataciones, nosotros disponemos de balones. Tú nos obsequiaste hace algún tiempo algunos y han sido de mucha utilidad. Nuestra conducta habitualmente es más quirúrgica, pero utilizamos mucho los balones para estabilizar y definir la lesión. Quisiera saber, nuevamente, que nos comentaras cuántas veces dilatarías a este paciente, por qué no lo operas el mismo día, ustedes tienen disponibilidad habitualmente de quirófanos como para seguir directamente a una operación. Y si lo operarías, harías probablemente un slide y no una resección. Me gustaría escuchar tus comentarios.
So I'm going to actually tackle this slightly backwards. So I stopped doing tracheal resections. And my logic is that if I do a short segment slide, then I don't have to remove every bit of the stenosis, because if you slide an area that has scar into an area that's normal, you'll get away with it. If you slide scar into scar, you have a problem. And if you do a slide, you've got a long oblique suture line, so there's less risk of a dehiscence, there's less risk of an anastomotic stricture. So slides are quite forgiving in that sense. And I've done, I don't know, 200, 250 slides, so I enjoy doing that operation. However, whenever you cut the trachea in two, there is always a small risk of a problem, whether the child gets infected, whether there's undue tension, whether you end up with a risk of a dehiscence or restenosis. With balloon dilation, the risks are extraordinarily low, and you still have a reasonably good chance of ending up with an excellent long-term result. And with the lesion that we've seen, I would think that again, I would estimate that I've got an 80% chance of winning as a long-term good result without open surgery doing balloon dilation. And so, boy, this age, I'd use a 9mm balloon. The first time, I would then inject a little steroid, divide the scar, balloon again, 7 to 10 days later, do it again, and then maybe a couple of weeks after that. And it would save a big open approach. The downside is you are going to get about 4 endoscopies. But even with the open approach, we usually do a few post-operative endoscopies as well. And so I tend to save the slides for the endoscopic failures, with the exception that if it is a congenital tracheal stenosis, that's usually better to do an open approach. That usually means you've got a problem of the exoskeleton of the airway, like complete tracheal rings, and that shouldn't be dilated. Hope that was of some help.
Sí, muchas gracias. Quiero hacer un comentario más. Porque este paciente es el primer paciente con una estenosis traqueal que nosotros tratamos en tiempos de COVID. Este es un paciente que recibimos en el mes de abril, en plena pandemia, con restricción de camas de UCI, con restricción de quirófano, con segregación de cirujanos. Yo pensaba que si decidía tratar a este paciente con dilataciones, tenía que volver 3 semanas después, regresar 3 semanas después, y quizás traer a quirófano al paciente 3, 4 veces durante la pandemia. Por otro lado, tenía la oportunidad de una cirugía, porque en ese momento sí existían camas disponibles. Hoy no tengo camas disponibles. ¿Ustedes considerarían el tiempo de COVID en el manejo de este paciente? Aquellos que gustan dilatar, quizás operarían si tuvieran una cama de UCI disponible, o aquellos que gustan operar, quizás tratarían de hacer dilataciones, pero en forma más distanciada. ¿Qué opinas, Gastón, de esto, o el panel, y también Mike, respecto de este planteamiento que es nuevo para todos nosotros?
¿Puedo opinar?
The advantage of balloon dilation is that it can be done as an outpatient. So the patient can come in, get dilated, go home, and it also buys you time. So if you did need to do an open procedure, you can plan it so that it fits in with what is happening in your hospital, given that in these COVID times, things are a lot less predictable. And, but everything is changing week to week at the moment. And if you can buy several weeks, then it's becoming a lot clearer how best to manage things if you did need to do an open surgery, for example, and admit the child to an intensive care and in the hospital after intensive care for a while. So it opens up a few options.
Gastón, muchas gracias, Mike. Gastón.
Nosotros, bueno, esto cambia, y la literatura que existe con respecto al riesgo de las cirugías y el COVID es bastante relativa y no es concluyente al 100% hoy. En nuestro hospital hay disponibilidad de camas en terapia. Yo creo que nosotros haríamos, en principio, el mismo abordaje, dilataríamos en la evaluación inicial y planearíamos la cirugía. Pero hoy en día se haría la PCR 48 horas con el hisopado, 48 horas preoperatorias. Si es negativo, yo creo que operaríamos. Y si el resultado del paciente es positivo, creo que es otra nueva discusión. Un paciente cursando una enfermedad por COVID, aunque sea asintomática, ahí hay otra discusión con respecto al tratamiento quirúrgico abierto. Entonces, creo que esa sería la única razón hoy por la cual dilataríamos nuevamente e intentaríamos que pase el periodo de enfermedad de COVID y reevaluaremos.
Ok, muy interesante. Quiero darle la palabra a Michele Ugasi porque él nos acompaña también. Michele desde Ecuador, Jaime también después, y luego iremos al chat.
Hello, Patricio. Hello, good morning to everybody. And a big hug to all my friends of our great World Air family. We are a group of almost 250 people, and I'm sure everybody is here today. Thank you, Patricia, again, for letting me introduce this question. And congratulations to you, to Diana, and to Alvaro for this amazing international meeting. My question is for all the speakers. Maybe Mike can answer first. There is a 3 question in one. Do you always try to delay your stenosis, or there are cases you decide to operate immediately? How many dilations do you need in average to fix a tracheal stenosis? And how and when do you decide the stenosis is getting better and you keep dilating, or is not going okay? And what signs make you decide to do surgery repair?
I'm going to tackle that first in 2 senses. I think if you've done 4 or 5 balloon dilations and it's not working, do something else. I would also, for our, we've got an extremely big audience here, 771, and you're dealing with a panel of open airway surgeons, all of whom are extremely competent at doing open airway surgery. And our audience is vast and includes a lot of people who will not be completely comfortable doing open airway surgery. And I think it's worth noting that balloon dilation, you are very unlikely to cause harm if you choose the right side balloon and use something like the Airway Card app to help you choose that. And equally, if you balloon dilate, you've got a good chance that that is all that will be necessary. And so again, our panel is a bunch of impressive surgeons who have no qualms about removing half the trachea if they need to. And again, in the context of the audience, balloon dilation is very unlikely to hurt someone and has a very good chance of helping someone. It levels the playing field. Everyone in this audience can be an airway surgeon with something as benign as that. So I'll hand back.
Gracias. Álvaro Pacheco, podemos ir a las preguntas del chat. Jaime quizás pueda contestar algunas porque estaba pidiendo la palabra.
Ok. Hay una pregunta para...
Hay 20 preguntas.
Sí, pero hay varias preguntas que se repiten. Hay una pregunta específicamente para Jaime, que dice, en el Hospital Infantil de México, ¿cuáles son los criterios para dilatación?
Jaime.
Bueno, esta es una buena pregunta. Yo sé que muchos van a pensar que a todos los opero, pero sí tenemos. Los criterios de dilatación son, por ejemplo, un niño que llega con obstruido, con bastante dificultad respiratoria, evidentemente necesita una dilatación. Tenemos varios pacientes que dilatamos, niños pequeños, niños de la terapia neonatal. Tenemos ciertos criterios y, por ejemplo, en estenosis traqueales lo hacemos casi exclusivamente como medida para mejorar al paciente. Un gran número, vuelvo a repetir, de esos pacientes con una resección asequible, que tengamos todas las de ganar preoperatoriamente, los llevamos a cirugía. A veces no te contamos con los balones suficientes, es un tema de financiamiento en el hospital, entonces eso nos hace probablemente hacer menos dilataciones.
Gracias, Jaime. Y tenemos también otra pregunta para Jaime, y que dice, en relación al postoperatorio, ya que tú decidiste operar a este paciente, en relación, esta pregunta no solo para Jaime, sino para el resto de los panelistas también. Como tú decidiste operar a este paciente, ¿cuál es el cuidado postoperatorio que tú haces a un paciente que le has hecho una resección de la tráquea enferma, en términos de la intubación endotraqueal en el postoperatorio, si el paciente queda intubado o no, cuánto tiempo queda intubado, lo sacas extubado del quirófano? ¿Cómo es tu manejo postoperatorio de estos pacientes?
Mira, conforme hemos aprendido a hacer estos procedimientos, actualmente niños, por ejemplo, el niño este niño de 5 años, a muchos de ellos los extubamos en quirófano, o si tenemos algún problema porque sobresedación o que el paciente tarda un poco en recuperar el automatismo, los pasamos a terapia, pero los extubamos al otro día. Ese es en una estenosis traqueal. Eso es un consenso ya hecho en el hospital, no los dejamos intubados más tiempo, solamente cuando están con un poco de acumulación de anestésicos y que vemos que no está muy bien despiertito, lo sacamos a terapia, pero al otro día lo extubamos. Si el niño despierta bien y lo vemos con buen esfuerzo respiratorio, lo extubamos en quirófano.
Disculpa, Álvaro, Marilena tenía, creo, alguna pregunta, comentario.
No la tengo en el chat, pero doctora Trozzi.
Yes, a very quick question. I was wondering, we are a big fan of the balloon dilation, and I think a case like that deserve a chance with the dilation, but in particular in COVID time. But I'm wondering if the presence of the recent fracture of mandibula could be a contraindication for endoscopic surgery.
Pato.
Sí.
Este paciente nos llegó a nosotros con la fractura de la mandíbula. Esta pregunta me la hizo el doctor Sandu también. Nos llegó a nosotros con la fractura de la mandíbula resuelta y sin ningún problema. ¿Habría cambiado, y esta pregunta para Mike, cambiaría la conducta de hacer una dilatación si yo tengo un paciente con una fractura de mandíbula inestable en el momento de encontrarme con la estenosis traqueal? ¿Preferiría un tratamiento abierto a un tratamiento endoscópico?
It's a problem-solving exercise. So if the child's mandible is unstable, then it would be reasonable to nasally intubate over a flexible scope. And you can then actually run the balloon down the endotracheal tube with the endotracheal tube just through the cricoid and dilate without any pressure on the mandible if you have to. And so, again, most of the time, if the mandible's been fixed, you can probably do a rigid bronchoscopy without threatening the mandible. But if you were concerned, there's always an alternative.
Okay. And you prefer to perform under fluoroscopy?
Actually, no. So one option is to either have a flexible telescope beside the balloon so you can see what you're doing. Another option is that you can estimate with a flexible telescope how far beyond the end of the endotracheal tube your stenosis is, and then using an identical endotracheal tube outside the patient take measurements and mark the balloon so it comes out the same length. So you can actually do it blind, just marking the balloon and put it through the endotracheal tube and dilate. So there's, again, you can use fluoroscopy, but it's just annoying. There's more equipment in the operating room. You don't really need it.
Okay, thank you.
Nos gustaría que el Dr. Rutter nos explicara en qué situaciones decide hacer una resección traqueal, digamos, de término terminal versus una slide tracheoplasty para una lesión de este tipo.
So I last did a tracheal resection 10 years ago, and I've done a lot of slide tracheoplasties. And so the nice thing about doing a slide is that you transect the trachea on a bevel. And so you can actually then remove the worst of the scar tissue on the same angle bevel, split the distal end of the back wall, the proximal end of the front wall, slide across itself, so you don't have to resect as much. Because if you've got a little bit of scar tissue in normal trachea, it's not going to cause a problem. And you can then do typically I do a running suture technique. So I've got a long oblique suture line. I haven't had to resect quite as much trachea. I've got less tension across the anastomosis, and there's a lower chance of an untoward problem. It doesn't happen very often, but when a tracheal resection dehisces, it's really quite inconvenient. And some tracheal resections under tension can get a web stricture at the same place. So I hope that answers the question.
Última opinión, doctor Gastón Belia.
Es muy interesante el comentario de Mike. Yo creo podría aportar algo para los que nos gusta hacer resección y anastomosis término-terminal, que hay un concepto sumamente importante que es que hay que anastomosar tejido sano con tejido sano. Pero si yo tengo una estenosis que es muy larga y eso va a generar mucha tensión, por más que yo no haga todo el tiempo traqueoplastías deslizadas, ese es un paciente donde la debo hacer. Y llevar a deslizar porque la resección me va a dar mucha tensión. Entonces, independientemente del gusto del cirujano, qué técnica esté más familiarizado y haga con mayor frecuencia, si la estenosis es larga y la resección es muy amplia para llegar a tejido sano, debo hacer una traqueoplastía deslizada para un buen resultado en ese paciente.
¿Y esa decisión la tomas en el quirófano viendo la tensión que tienes entre los dos cabos? ¿La tomas antes? ¿Tienes una idea más o menos clara de cuántos anillos son tu límite para hacer una resección versus una slide?
Más o menos esa decisión se puede tomar antes porque va a alterar un poco cada paso de la cirugía. Probablemente hagas una sección de la tráquea en forma diferente cuando vas a hacer un slide o una resección y anastomosis término-terminal. Así que en este paciente que se discutió, yo no tengo muchas dudas que voy a hacer una resección término-terminal, pero si yo tuviera dudas, lo plantearía preoperatoriamente y terminaría de darme cuenta en el quirófano, pero ya lo puedo inferir con anticipación.
Perfecto. Doctor Varela.
Gracias a todos los panelistas. Tenemos que continuar. Nos hemos alargado, pero creo que los comentarios han permitido que todos los asistentes se mantengan online. Creo que ha sido muy interesante todo y por eso, conscientes de que nos hemos alargado en el tiempo, creo que ha sido muy, muy beneficioso para todos. Finalmente, este niño lo dilatamos 2-3 veces, estaba con corticoides desde hace mucho tiempo, por lo tanto no podíamos hacer una cirugía bajo una dosis de corticoides que tenía este paciente bastante alta durante 2 o 3 semanas. Y finalmente hicimos un par de dilataciones y planificamos la cirugía un mes después de haber suspendido los esteroides. Abordamos por cuello y dilatamos. En este caso, como decía Jaime, al paciente lo extubamos en el quirófano y este es el aspecto del niño 2 días después en la unidad de cuidados intensivos. El resultado pre- y posoperatorio, ustedes podrán ver que la anastomosis fue prácticamente entre el cricoides y el primer anillo traqueal. Hay una cicatriz acá que dilatamos el día de la endoscopía de control y el paciente fue dado de alta ese mismo día y no va a requerir probablemente ningún otro procedimiento. Terminamos esta sesión. Diana, nos gustaría preguntar nuevamente, ¿ustedes dilatarían, operarían? ¿Cuál es la opinión de la audiencia? Por favor, elijan una sola opción. Les recuerdo que el 78% en la primera encuesta sugería una dilatación.
Wow, qué interesante. Se están igualando los resultados. Ahora se separan nuevamente.
¿Qué te parece, Gastón? ¿Cómo va la estadística? Porque tienes tono de comentarista de fútbol argentino.
No la puedo ver, Pato, yo la estadística aquí.
58 dilatación, 43 cirugía.
Muy bien.
Subieron nuestros bonos.
Pero qué...
Ok, ha votado el 50% de la audiencia.
Bien, Álvaro, ¿tienes la palabra para continuar?
Voy a finalizar la encuesta. Ok. Ahora voy a compartirles. Hemos terminado esta sesión.
No, volevo dire una cosa.
Álvaro.
Ok.
Ya. Catherine, hola, no te había saludado. Álvaro, tienes la palabra.
Ok. Yo ahora los voy a dejar con el doctor Reza Rabat, que es profesor de otorrinolaringología de la Universidad de Harvard. Trabaja en el Hospital de Niños de Boston y él nos va a hablar ahora sobre el manejo de los clefts laringotracheales. Dottor Rabat.
Il Covid soprattutto è meglio dilatare piuttosto che operare. Secondo me è il contrario.
No está.
Thank you, Alvaro.
Solo, meglio piuttosto che far tornare il paziente 4 volte, no?
May I start?
Yes.
Yes, please. Please start.
Well, Diana, Patricio, Alvaro, thank you very much for your kind invitation. Let me share, I hope I do this correctly.
No, stenosi tracheale abbastanza. Quelle sottoglotiche è diverso, ma stenosi tracheale si vanno bene.
Michele Torre, ¿puedes silenciar tu micrófono, por favor?
You have to allow me to share the screen with you.
Ok. Diana, ¿puedes autorizar a Reza de compartir su imagen?
Está habilitado. Todos los panelistas están habilitados.
Ok, Reza, you can share your screen. The screen is available.
It is not allowing me to share it with you for some reason.
Diana.
Doctor Reza, demora un segundo en retomar su señal. Voy a encenderlo.
Okay, we will turn you off just for 10 seconds and then you will be with us again.
Por favor, ¿puede intentarlo nuevamente?
Can you try again?
It says that you have to allow me to share.
No, acá, ok.
Now let me do this. Maybe give me 1 second. Can you see my screen now?
Acá estamos.
Can you see this?
No. Todos están habilitados. Podemos...
There should be something on there, Reza, that says share screen.
Yeah, I just... And it says, should I say all panelists or host only?
Ya, todos los panelistas pueden compartirlo.
Yeah, all panelists.
It is on right now.
No.
And you are not seeing anything?
No.
Let me try this one more time.
Yeah, just click on the green button. Don't worry about the advertising because there is one in white. Just go to the green button.
Can you
close the advertising?
Yeah, there is no advertising for me.
Okay.
Can you see it now?
No, we cannot see it yet. You have to click on the green button only, not on the small gray arrow that's besides it.
When I press down, it gives me a blank white screen, and it says Basic, Advanced, and Files. So it does.
Exactly. That's the screen you should get.
Okay. And then do I need to push the share?
Yeah, you have to choose which screen you want to share. That's probably your PowerPoint screen, and then click share. You should have a few screenshots there, probably Chrome or whatever, and then your PowerPoint.
We tried this the other day. For some reason, when I pressed on it, gives me a sign for Microsoft, Google Drive, Box, Dropbox, but it doesn't allow me to get into the screen.
So probably those are the windows you have open. So what you have to do is try to go to PowerPoint, open your presentation, and then come back to Zoom.
So I'm in a PowerPoint right now. And then what would you like me to do?
Now go to Zoom and click share screen. Now you should be able to see that PowerPoint screen. So you can choose it.
It's not allowing me to do it.
Yeah, okay, but you did right the other day. Maybe you can turn off and try to connect you again with us with the Zoom. So do it everything all again, all the process, and we can follow with Rusty probably.
Yeah, why don't you have Rusty proceed and then zoom out and zoom in again?
Yeah, you can turn off everything,
okay.
your signal, your connection, and back with us, and I'm sure you will do it okay.
Okay.
Okay, let's follow with Rusty.
Let me just start.
¿Me escuchan?
Sí.
Sí.
Ok. Para mí es un honor invitar al doctor Russell Jennings, director del Centro de Cirugía de Esófago y Tráquea del Boston Children's Hospital. Russell nos compartirá su perspectiva del trabajo multidisciplinario con la conferencia Centro Aerodigestivo, trabajando como un equipo. Russell, bienvenido, tienes la palabra.
Okay, sorry, I hit my space bar and it just went through to turn my microphone and just run through the slides real fast. Thank you so much, Diana and Pato, and for all the panelists. This is really an honor. 1,000 attendees is pretty awesome. Diana, congratulations. You've done an amazing, amazing job. She asked me to talk about how to develop an aerodigestive team, and I'm actually don't really know how to do that. I have no disclosures, but I think I've seen a lot of different types of aerodigestive programs. Some are just, coordinate an ENT and a GI discussion. So those are some of the programs. Some of them actually bring in pulmonary as well, and they just want a coordinated team. So they have a multidisciplinary conference, which is great. And it brings in some good cases and you get some coordinated care. My goals are a little different, and that is to get committed specialists, solve challenging problems, because life is too short to do anything less than absolutely awesome. So I set out to develop a reference center of excellence, and the EAT Center is the example we can use. I've started other programs as well, but this is the best one. And what it takes is interested, passionate leadership, the focus on the problems, particularly the ones that are not solved or the ones that are misunderstood. Using a multidisciplinary approach, you get everybody's ideas is terrific and everybody's voice is valuable. And as you get this, the volume just starts increasing. Every rare problem becomes a common problem. If you walk around our hospital right now, you think esophageal atresia and tracheomalacia is an infectious disease. Everybody's got it. And by that, you start building experience. Then you can start doing trials. You can test things. You can get more experience. You report the outcomes. Everybody gets a little bit of academic advancement. And basically, you improve outcomes and you markedly decrease the overall patient care expense. How does a reference center decrease expenses? Well, there's a recent white paper by two of the largest companies in the US, the insurance companies, and they followed two groups of complicated patients. One received local care and the other one traveled out of their city to the center of excellence for their different specialties. There's different types of cases. At 1 month, the local care was much cheaper, about half the cost, because of the increased travel and lodging expenses for the center of excellence. And frankly, when you go to a center of excellence, we charge more, so it costs a lot more money. But at 1 year, because there were much fewer complications, much fewer hospitalizations, the center of excellence was about half the cost within a year because you had better outcomes for complicated patients. So why did we start the EAT Center? Well, I started because we seek truth. We're not trying to advertise, we seek honesty. And we focus on unsolved problems. There are just so many people out there who can do the standard treatments for the common problems. Why would I want to participate and compete on that arena? We want the blue ocean where there's nobody out there to work on these complicated problems. So we also focused on the complications from standard care. And because I'm a pediatric surgeon first, I worked on esophageal atresia, which has a horrendously high complication rate. It's one of the toughest problems that surgeons face. And I'm passionate about unsolved problems, and we'll get to these problems later. So what does it take to start? You have to get people who are passionate about the problems. If they're not interested, if they're not leaning in, as the current stand is, then go on to the next person. I don't care how smart they are. If they're not interested, it's not going to work. And you want to get increasingly complicated patients and start attracting other people's complications so that you learn how to do that better. And by just getting these referrals, you start getting these rare problems become quite common. And you start building the experience and you get to be self-critical. And fortunately, we have panels like this where people will give me great ideas in the form of constructive criticism, sometimes quite vocally. And that's all good. That's what we need. So how did we start? Well, 10 years ago, I started in the esophagus because that was the most interesting thing. And it's a hard problem to fix when you have esophageal atresia and injuries and fistulas and stuff like that. The first thing we tackled was what we call long gap esophageal atresia. We learned how to grow the esophagus. How do you grow it? Well, there's pediatric cardiac and pediatric general surgeon from Minnesota developed what he calls the Fokker technique, what we call the Fokker technique. And basically it's just stretching something sort of like the Ilizarov technique for bones or breast implants for chest wall or the things where you lengthen the jaw. It's the same operation. We just stretch the esophagus. It grows. We learned how to do difficult anastomoses. It's very technical to do a good esophageal anastomosis with no complications. And this is sort of the outline of it. The basic thing is make esophagus as long, the anastomosis as long as possible, and roll the mucosa to the inside. So what did we learn in the first couple of years? To take a case like this, which is impossible to fix directly, grow it up over 3 weeks so we have more esophagus than we need and end up with an intact esophagus. Now it's absolutely routine. We've done about 150 cases. I think I have 2 or 3 kids in the hospital right now who are growing their esophagus. We also, as we were doing this, started getting all the salvage surgery for other institutions who had major complications. That's a much bigger group of patients, maybe 500 or more patients. And we also started getting just simple anastomotic strictures, which are not that hard a problem. We get about 100 cases a year, which we have to repair. And we get congenital strictures. I didn't even know about congenital strictures. When I started this, they're highly associated with esophageal atresia. And so now we can recognize them and treat them early without getting the problems associated with inadvertent treatment. And we also learned to treat anastomotic strictures from other institutions. We've done about 1,200 cases. We do hundreds every year now. It's just part of our routine business. We also learned that TEFs, or tracheoesophageal fistulas, are very tough to repair. We had to learn how to do that. And while we're doing all this, these kids are having trouble breathing.
Oops.
That's not true. It is a major life-threatening problem in many kids, and we had to figure out how to address that. We also learned a lot about the thoracic duct, and we won't talk about that today. So our second strategy was to start the Airway Center about 2 years or 3 years after that, and involve ENT and ORL. Dr. Rabar here is very deeply involved in the program, and get pediatric pulmonary. Because the truth is, every time you operate on the esophagus, you're operating on the airway. And every time you operate on the airway, you're probably operating on the esophagus. So you better be facile with both. And this is just showing tracheomalacia. Many people just don't treat this because they have a barky cough, recurrent infections, hypoxic episodes. Maybe you put a tracheostomy into them and you think it's good enough. But in fact, it goes on to chronic infections, bronchiectasis, et cetera. So we had to learn on our own about tracheomalacia, reviewing the literature, and then decide we had to develop our own classification system because nothing out there worked. And so we needed to understand, needed a way to talk to each other. We need to correlate it with signs and symptoms and correlate it with outcomes. So really understand it once we did this. It's based on anatomy, which parts of the trachea are covered by which vessels and what other structures. And we divided into cervical trachea, vascular trachea. This is more of the aortic trachea. And the main stem's also by the vascular coverage. And I won't get into the details, but it all has to do with the vascular structures. We also discovered there's a lot of different types of cartilage shapes, and the cartilage matters. The shape of it matters. In Japan, they use the oblateness index right now, which doesn't describe the cartilage very well. But we now will describe the cartilage by UC and bow shape. And the broader the cartilage, the more bow-shaped it is, the broader the posterior membrane and the more mobile it is. And that's the excessive dynamic collapse problem. We also discovered there's different collapses. Sometimes the cartilage is malformed, sometimes vascular compression. All of this fits into the classification system and matters. So how do you figure out the airway? Well, we had to figure out how to do a complete airway evaluation. Everybody knows how to do an awake flexible airway exam. Dr. Rabar and Dr. Choi had taught us how to do this, and they actually do it all for us. So we can assess the vocal cords, rigid laryngoscopy. We found a 40% incidence of laryngeal clefts in esophageal atresia kids. So this is huge. This is part of their problem, and it only accentuates the problem with tracheomalacia. And then we defined the 3-phase dynamic bronchoscopy because each phase gives us different information. Shallow breathing is the compression. The coughing tells us the maximal collapse and the severity of the malacia. And the distension reveals other problems like TEFs, tracheal diverticuli, and like today's case, the one I just ran away for, an aberrant bronchus off the trachea. And then if we need to, we do other investigations like contrast studies, et cetera. So we all know, when we went to doctor school in the 70s, they came up with this little trick called an anterior aortopexy to help for tracheomalacia, and people do it. But most people say it doesn't really work well, and they're right. Why is that? Because the problem is on the back of the trachea, not the front, and you need to stabilize this back. So once we figured that out, we figured out how to do what we now call the posterior tracheopexy to stabilize the posterior membrane by moving the esophagus out of the way. And we can still do, if we need to, an anterior tracheopexy and or aortopexy in about 15% of kids. Here it is diagrammatic. So we've made a lot of advance, and this is just showing us intraoperatively how we do it. It's a very precise operation. Here's the surgeon putting the sutures in, and here's the bronchoscopy guiding the sutures, because the position of the suture and the angle of the suture towards the spine matters a great deal. And it's very common for us to take the sutures out and do them again because we're off by 10 or 20 degrees. We don't get adequate opening. But ultimately, our goal is to get that trachea, which closes at maybe -10 on suction, to be wide open at -50, at least 50% open at 50 centimeters of water suction. And we achieve that the majority of the time. And this shows our pre-op right here. We can see where the child, little coughing, is closing his trachea on the left, and you can see there's up to -50, and you can see that trachea staying open. So this is a good result. We then reported these results. We're currently reporting the first, I think, 400 patients, but this is our first 100 patients from 98. Anatomically, we had very good results, statistically significant, highly significant for all the different regions that we corrected. And symptomatically, both coughing and noisy breathing, as well as important things like ventilator dependence and boost bells, a markedly significant event in essentially stopping all the ALTs. So this operation works, and it works for very logical reasons. So as we're moving along in the tracheal center, what did we learn? Well, we learned that lots of types of tracheal malacia. It's not one disease. There's cartilage problems and vascular problems and intrinsic stenoses and external compression and membrane problems. There's also chest wall problems, spinal problems, and rib problems that accentuate tracheal compression. We learned to be associated with laryngeal clefts. We also found out when we get referred cases, there's about a 50% injury rate to the recurrent laryngeal nerves after people operate on the trachea or the esophagus. So this is a huge deal. We also found a high incidence of recurrent TEFs. We've developed a classification for these as recurrent, congenital, and acquired. They're all treated differently, but we can say that now that we've figured out how to fix TEFs, we have a 0% recurrence rate. And we just sent that out for publication, 0%. We also will fix the tracheal malacia at the same time. So now we have benefited that airway in 2 ways. We've also learned how to resect tracheal diverticuli so the airway looks normal and doesn't hold pus and infection in the diverticulum. So now we fix the airway in 3 ways. And we've learned a lot about stents and splints. We won't discuss that today. But as we went along, we noticed that the vascular compression, now that we fixed the esophagus and airway, the vascular structures are a huge issue where they lean on the trachea and compress it. So it's not just malacia, but it's also compression. I'm going to sort of go through the other programs quickly, but we learned that not only is there AP compression on the trachea, there's also transverse vascular compression, other types of vascular compression, combined often with other issues like malacia and abnormalities. There's a high recurrent laryngeal nerve injury rate with cardiac surgery, and there's a high incidence of loss of chest domain in cardiac patients and vascular patients partially because of the sternotomy and the way it heals is sort of bent in. As a pectus deformity, we've identified spinal deformities and rib deformities that lead to loss of chest domain. And so we've come up with many innovative solutions for these vascular compression problems on the airway. Descending aortopexy, aortic uncrossing, finding the artery of Adamkiewicz. What do we do about the diverticulum of Commerell, which is very common? Aberrant subclavian artery repair techniques, of which we now have several, including reimplantation. And rotation esophagoplasty is critical when you fix a vascular ring to get the esophagus out of that scar tissue that holds it in the vascular ring. So then, as we moved on, we learned that we can fix the vascular problems, but that sometimes it's the chest wall that's the problem. There's simply not enough space. So how do we make more space? Well, working with our orthopedic colleagues now and plastic surgery team, we can work on the spine and the sternum and the ribs to give more space. We've learned there's so many different types of thoracic insufficiency, kyphotic deformities, procedure related after orthopedic problems and sternal deformities. And very often they're combined, cardiac, tracheal, vascular, esophageal, pulmonary, and chest wall, all in one mix. And it's only somebody who has the multiple perspectives that can go attack these very complicated problems. So where do we stand now? Our most recent addition, Dr. Rabar is quite supportive, is helping out, is the recurrent laryngeal nerve program, which helps understand my questions earlier. We are on this like a chicken on a June bug because there are so many nerve injuries from other surgeons. We do everything we can to prevent injury, but sometimes injuries still occur, although for us, fortunately, it's probably 1%. And they usually come back. So now we have to define the path of the recurrent laryngeal nerve, not only in normal anatomy, but now in the vascular patients, so right arch anatomy, recurrent nerve injury, recurrent pathway is quite different than a left arch. What do we do about aberrant subclavians? Where are the nerves in those cases? And where are we nerves in people who've had multiple procedures? And for that, we've learned how to do nerve stimulation. We've now started in the last probably 6 months, every single patient on each service gets recurrent laryngeal nerve monitoring, regardless of the procedure we're doing, neck, chest, sternum, and vascular rings. And we're now rolling this out to cardiac surgery because of their high injury rates. That's just starting, but it's just starting to work. So what did we learn about those? We're learning more about dual channel monitors in every kid, APS when we need it. We've had to totally change the anesthetic techniques. And we're learning about the pathways of these nerves in these different pathologic conditions. And are very interested in how to salvage recurrent nerves that have been injured. So that's sort of our next step. So how do we develop a team which is growing fast, making incredible inroads? Well, it's because everybody's an expert. They truly are world-class experts in their specialties. We're passionate and we're interested in these problems. Curiosity is fostered and very much encouraged. And we are all absolutely tenacious. We will not give up until the problem is solved. And we're not afraid of criticism. We welcome it. We want comments to where our blind spots are, so where we can improve, because that's how we get better. Everybody's pretty friendly, and everybody's available as they can be. So what do we do? Well, we have a simple process to define the problem. Our goal, we have sort of a motto: understand the problem, assemble a team to review the problem, and then figure out how to define it and treat it. It's really interesting when you look at a problem, whether you look at a blood vessel or an airway or heart or esophagus, all this other stuff is around it. You cannot separate the thoracic duct and lymphatics from the esophagus, from the airway, from the nerves every single time. Sometimes you have to address all of these problems, and that's where it takes such a sort of multi-perspective team. All of these people are required. You have to have interventional radiology as well as plastic surgery. Nutrition is critical. All these people are required. And to have less than all these people makes your team that much weaker. So why do we develop? Because we have passionate leadership. We focus on difficult problems and to solve them. And all these rare problems are very common. You walk around our hospital, you think everybody has a TEF or a tracheomalacia or a vascular ring. But we keep trialing, we keep being critical of ourselves. So I'll tell you the secret to developing amazing centers. And it's pretty simple. One is the visionary leadership with a wide open mind to tackle the really hard problems. There's always a better solution. We go from open surgery to dilations to incisions. That's a good trend. Altruism is every person on the team has to support the other person, even if it's not to their benefit. I'm not on every paper. I don't want to be on every paper. I want every person to be excited, want to light their fires and watch them soar. Everybody gets credit when things go well, but when things go bad, it's totally my fault. I take responsibility and we'll solve that problem. It's about the patients. It's not about the team. And so we're all very humble. Nobody's going to be bragging about anything. Although sometimes it sounds like I'm humble bragging when I talk. I'm just very proud of the program. And perhaps the most important issue is about being having integrity. Everything's open. We report everything. There are no secrets to us to our team members, to the patients, or to the hospital. There's a can't be. So I hope this gives you some ideas of how we've been able to develop the EAT Center here in Boston. Diana.
Gracias, Russell. Fantástica conferencia. Siempre me hace vibrar escucharla y nos motivas a fortalecer día a día nuestros centros. Creo que vamos por buen camino. A continuación, el doctor Reza Rabat va a continuar. Vamos a hacer algunas modificaciones, si estamos de acuerdo, doctor Reza. La última charla, que es vía aérea en tiempos de COVID, podemos hacerla solo como con interacción con nuestros asistentes, resolver todas sus preguntas. Y pido un excusa un momento. Diego Preciado, ¿estamos? ¿Diego está?
No, Diego no está. Se tuvo que ir.
Ok, perfecto. Entonces, vamos a hacer la charla de hendidura laringotraqueal y a continuación abrimos la parte de preguntas para hablar de vía aérea en tiempos de COVID. Adelante, Reza.
En resumen, disculpa Diana, Diego se ha despedido, tenía un compromiso a esta hora. Él lamenta mucho no poder continuar con nosotros, pero creo que ha tenido una participación fantástica. Y como decía Diana, vamos a seguir con Reza Rabat, con la charla de Cleft, y después se van a abrir las preguntas para el chat de la conferencia del Dr. Jennings y de Reza. Muchas gracias. Reza, tu micrófono está apagado. ¿Puedes encender tu micrófono?
Ya está prendido, ya lo
ya está prendido.
Can you hear me okay?
Yes, we can hear you okay.
I apologize, but for some reason, can you see my screen?
No.
Okay, I don't know. Okay. So you have to tell me what to do, because I have tried to share this multiple times, but it is not working, and I'm not sure what the issue is. We tried this with you, but it tells me that the host needs to allow me to share.
Diana, yo creo que
presiono la
más
opción
fácil es subirlo
de compartir todos los panelistas. ¿Quiénes pueden compartir? Todos los panelistas.
Diana, yo creo que la opción mejor es subirlo a co-host y listo.
Ya lo habías hecho antes y lo estoy haciendo en este momento. Reza, ¿puedes intentarlo de nuevo, por favor?
Okay. And if it doesn't work, then we can just talk about this. So it says, right when I say, it says, let me, can you see the screen now?
No.
You do not? Okay. So Diana, I don't know what to...
Compartir pantalla. Inténtalo de nuevo. No, inténtalo de nuevo.
Bueno,
I push the share screen, but it gives me a desktop, iPhone, and iPad, but it gives me a...
Okay, so click on desktop.
We have a B plan. So Pacheco, please open your micro. Reza, if you are agree, we can follow with the Alvaro Pacheco's videos.
Please do so, yes.
Okay, and then we can follow with the answer and question from the audience.
I think that's a better idea.
Okay, let's go Álvaro.
Okay.
And after Álvaro videos, we will follow with the chat again, an open chat. Álvaro, abre tu micrófono. Oh, todo de nuevo. Abre tu micrófono, Álvaro, por favor.
Estaba con
Álvaro.
el micrófono silenciado. No. Ok, ¿me escuchan ahí?
Sí.
Ya, ok. Voy de nuevo entonces, perdón.
Perfecto.
My bad. Ahí sí. Primer caso. Entonces, es un paciente de 3 meses de edad que tiene estridor inspiratorio moderado desde el día 10 de edad. No ha tenido crisis de cianosis, no tiene retracciones, no tiene dificultades respiratorias evidentes. Se atora frecuentemente y tose cuando se alimenta. Todas las alimentaciones son con tos y con atoros. Y ha crecido bien y ha subido bien de peso sin ningún problema. Este es un paciente visto a fines del año pasado. Y esta es su endoscopía.
Álvaro, ¿puedes mostrarlo nuevamente? Estás con el video encendido.
Sí.
No corre bien. Nuevamente. Gracias.
Ahí va.
¿Puedes explicar un poco, Álvaro, lo que estamos viendo?
Ok, aquí.
O quizás reza.
Yeah, well, I mean, I'm looking at the vocal cord, and it looks like this is I mean, to me, just looking at it, it looks like a normal larynx with degree of laryngomalacia. Epiglottis appear to be curled. It's not a classic presentation, at least without, just by looking from here as a laryngeal cleft.
¿No le parece, doctor Rabar, que esto puede ser un espacio interaritenoideo profundo, más que en inglés se conoce como un deep notch?
It's very superficial, at least. You know, it's hard to know that by just without probing it. But you know, if you freeze that picture right now, it looks like the vocal cords are away from the groove. So this is, at least just by looking this video, it is mostly suggestive to me of a degree of laryngomalacia, just because of the shape of the epiglottis and the tightness exactly of the area epiglottic fold.
Okay, we'll show another video. This is a 2-year-old girl, una niña de 2 años con estridor inspiratorio moderado desde la primera semana de edad, con episodios ocasionales de cianosis, de retracciones, de dificultad respiratoria y que también frecuentemente se atora y tose cuando se alimenta. Y esta niña sí tiene dificultades para crecer. Esta es una niña que ya tiene 2 años y tiene problemas de peso y de talla. Y esta es su endoscopía. Que parece muy similar a la endoscopía previa. Y en la que, bueno, sí vemos que hay colapso supraglótico también.
Exacto. Are these examinations done with suspension or is it just by laryngoscopy?
Solamente con el laringoscopio, no en suspensión. Y vamos a mostrar ahora otro video más, un tercer paciente. Este es un paciente gentileza del doctor Varela, que él vio hace varios años atrás. Es un niño de 10 meses con estridor leve desde las 2 semanas de vida, sin cianosis, sin grandes dificultades respiratorias y con problemas de atoro y tos al alimentarse.
Can I ask you, can you freeze that picture for a second?
Oh.
When you are probing, if you can freeze it, that would be very helpful. You had a good view. It's okay.
I'll do that. It stops too late.
It's okay. It's difficult.
Yeah.
So that's a very good picture. So to me, just again, it is very difficult to make a diagnosis and not being there and not looking at a three-dimensional view. But this looks like a normal larynx to me. It does not look like a type 1. If you notice if you put the arrow where the notch is, exactly. So the thing that I usually teach everyone is that if you're standing in that notch, if you're actually physically standing on that notch, you have to take a step down to go to the vocal cord. And that's a normal level of the vocal cord. The notch and the vocal cords are not on the same level. So exactly where you have your dot, if you put your arrow where the notch is again, one more time, if you imagine yourself standing on that area, for you to get to the vocal cord, you need to step down. That's the normal way of the larynx. So at least based on this, I would not consider this a type 1 clef or even a deep notch, because there is a little bit of a space above the vocal cord. But if you wish, I will be happy to talk about that afterwards when we have more time for discussion.
Álvaro.
Sí, bueno, la razón para mostrar estos 3 videos es precisamente que todos tenemos muy claro que el cleft grado 1 es una hendidura laringotraqueal o laringofaringea en realidad, que llega hasta el nivel de las cuerdas vocales. Y todos tenemos más o menos claro que eso da síntomas y que eventualmente necesita tratamiento la mayoría de las veces. El problema es con estos casos que digamos, son un cleft grado 1 propiamente tal, pero que tienen abundante sintomatología de aspiración. El doctor Navar le parece que la sintomatología de aspiración puede ser solamente secundaria a la laringomalacia. Tenemos niños de distintas edades. En el caso previo teníamos un niño de 2 años que tenía abundante sintomatología de aspiración.
So let me know, do you want to show the rest of this or do you want me to talk now?
No, por favor, me gustaría su opinión.
So, and please let me know if I'm talking too much, if you have other cases to show.
No more cases. No more cases.
Okay. So I think, Patricio, you raised the most important question. And I think if I can, and I'm sorry that the videos are not connected, if I can only make one statement, is that when it comes to the type 1 cleft, it is not the way it looks for the treatment. We can all make a different diagnosis of what a true type 1 or a deep notch is. So the treatment should really not base on how it looks, but mostly on its symptoms as you described. So for example, and to me, what is very helpful is the role of swallow study. And I will tell you what I mean by that. If you have a 2-year-old who coughs and you do a swallow study on that patient, and the oral phase, pharyngeal phase is completely normal, and the issue of the aspiration is only at the laryngeal inlet, that is more suggestive of a possibility of a laryngeal pathology causing aspiration, such as a cleft. But if you do a swallow study on that 2-year-old and the entire oral phase, palatal phase, tongue mobility is abnormal, then that aspiration may be more of a neuromuscular discoordination. So that's why I personally think that that swallow study is very helpful for me to decide where is the site of the location. Is that helpful?
Yes, sí, es muy útil. De hecho, tenemos unas preguntas para el público. Diana.
Sí.
Álvaro.
Sí.
Antes de ir al chat, me gustaría escuchar también a Mike y también a Reza nuevamente. Estos 3 casos los hemos presentado. Son casos que hemos diagnosticado, el primero hace casi 10 años y los últimos prácticamente este año. Nosotros creemos que estos casos son un deep notch. En el video se puede apreciar más o menos que el músculo interaritenoideo está sano, no está interrumpido como en los type 1. Entonces, ¿hay alguna diferencia entre un deep notch y un type 1? Entendí que lo que decía el doctor Reza, acá más que la imagen son los estudios y la sintomatología. Me gustaría también conocer la opinión de Mike, uno de estos casos, el del 2012. De hecho, yo lo comenté con Mike en ese entonces y él me dio un muy buen consejo.
So I think that Reza and I feel very much the same way on this. It's not the anatomy, it's the physiology. It's not whether you've anatomically got a deep notch or a type 1 cleft. It's whether physiologically you've got someone who is aspirating or has symptoms that would be consistent with aspiration. And ideally, you would like to get something objective out of that, though there are times there are exceptions. Effectively, if you've got a type 1 cleft and you don't aspirate, who cares? If you've got a deep notch and you do aspirate, you might want to think about doing something about it. That's my view, and I think that's. I think Reza and I are very much on the same page with that.
I absolutely agree. So let me give you. I cannot really think of a general surgical. Let me use a cardiac analogy. If I have a newborn who has a VSD, small VSD, but that patient is completely asymptomatic, and that VSD is not doing anything, even though there is a hole in the heart, the cardiologist may monitor that. So the fact that there is only a small heart, a hole, is not an indication to intervene. They judge it based on the echo or cardiac physiology. Now, I would, for the sake of this conversation, I make a statement that may sound a little bit controversial, but it makes the situation a little bit easier to understand. Let's consider a deep notch and a type 1 cleft are the same. It doesn't make any difference. Let's make them all in the same categories and don't use a different term. Regardless of whether we call it a notch or a type 1 cleft, the management is based on the fact that you have ruled out any other issues that may cause aspiration from a pulmonary perspective and GI perspective. You know the vocal cords are okay. And if you manage them medically and it fails, then whether it is a notch or a type 1 cleft, in my opinion, it would benefit from a surgical intervention. I hope if you think of it in that context, it makes it easier to come up with a treatment plan. I don't know, Patricio, if that helps or not.
Excelente. Creo que hemos abordado un tema de interés transversal a toda la audiencia y estamos muy contentos por eso. Diana,
Bueno,
Álvaro?
Patricio, may I use one more example?
Of course.
So for the otolaryngologists who are listening to this, I know there are 614 people on the chat. They can relate to this. When we describe laryngomalacia, we are not really focused on how does the larynx looks, because we have patients whose, when we do scope in the office, the degree of laryngomalacia is so bad that you don't see anything. But if that patient's airway breathing is manageable and feeding is manageable, we don't operate on laryngomalacia, we'll just watch them. Now on the other extreme, there are some children, when you scope, they have a mild case of laryngomalacia, but they desaturate, they turn blue, they are aspirating. For those patients, we operate. So I think the type 1 cleft, you have to think of it in that context. It really, it doesn't matter how it looks. What really matters is, Mike said, physiology, I would say function. It's the same thing. It really depends on how it functions. I hope that is helpful. Now, if I also say one more thing, because I know you are a pediatric surgeon and I know Rusty is listening to this. There is a complete difference when we operate on the laryngeal cleft versus when we operate on esophageal atresia. And the expectations are different. So I'll give you one example. When you operate on an esophageal atresia, your success is defined by repeating an upper GI endoscopy that doesn't show a hole. But you do not judge your success of whether this patient has severe reflux. You don't judge it whether the manometry is normal. You don't judge it based on the fact that the peristalsis of the esophagus is normal. But when we do a cleft repair, your judgment for success as failure really depends on its function. It has to be able to, this child has to be able to tolerate thin liquid. So I think it's important also to understand that the way we approach the cleft is really based on its function, not necessarily based on its anatomy. I hope that's helpful as well.
Yes, and that's very helpful.
Álvaro, tu video lo puedes encender.
Gracias.
Voy. Ahí sí.
Ok, Diana.
¿Pato?
Sí,
ahora vamos a hacer algunas preguntas. Vamos a hacer un poll para la audiencia y para los panelistas, que quiero que lo discutamos. Diana, entonces.
Ok. Bueno, quedan abiertas las preguntas y vamos a tratar inquietudes que tengamos respecto a la época de COVID.
Diana,
dime.
¿Vamos a hacer el poll?
¿Vamos a hacer el poll o no vamos a hacer el poll?
Ya,
Sí, claro.
están como conferencistas, están subiendo, ya los he ascendido.
Sí, no, pero ¿tú tenías el poll listo para estas preguntas o no? Ah, no.
Sí.
Laryngeal cleft, ya. Ah, ok. Ahí vamos. Entonces, ¿qué estudio le harían al paciente? A estos pacientes. ¿Le harían un estudio endoscópico, un FIS? ¿O le harían una videofluoroscopía de la deglución? ¿O le pedirían ambos?
Bueno, todavía hay mucho entusiasmo.
Sí.
Hay al menos 200 entusiastas, asistentes y mucho más. Está creciendo. A ver si podemos llegar a 500, porque todavía hay 600 conectados. O a 300 quizás, Álvaro, estaría bien.
A la mitad, por lo menos a la mitad. Deberíamos
La
llegar.
mitad.
Ahí vamos, ahí vamos.
Es magnífica la presencia que hemos tenido de los asistentes. Yo les agradezco enormemente.
¿Pueden apagar los micrófonos?
Vamos a apagar el micrófono.
Diana ha encendido los micrófonos de muchos asistentes. Le pedimos silencio un rato, por favor.
Ok, entonces tenemos que...
Me gustaría que Mike o Reza comentaran este resultado, Álvaro. ¿Es posible?
Sí, están ahí escuchándonos.
Bueno, tenemos...
I think the only thing that's topical at the moment is that fees evaluations in the time of COVID are kind of on the back burner just a little bit. And yes, absolutely, we would typically recommend both, but at the moment, we're not doing fees because of COVID. And so we'd definitely go the video swallow study. Even then, we're still getting our speech therapists to garb up.
Marilena, any comments? ¿Del resultado?
We used to do just we have a very small practice with the fees. We do only for older child because in our opinion needs some cooperation that we cannot guarantee when they are too young.
Hugo Rodríguez, ¿algún comentario de estos dos exámenes? Hugo Rodríguez, tienes que encender tu micrófono.
No te escuchaba, perdón, Pato.
¿Algún comentario de este resultado del FIS y videofluoroscopía o ambos?
Yo creo, estoy de acuerdo con ambos, con Mike y con Marilena, que primero hacer la videofluoroscopía y en estas épocas de COVID, sí, el FIS no va. Y no es fácil hacer FIS en chicos que tan chiquitos. O sea, en realidad el diagnóstico por estudio funcional en chicos tan chiquitos confunde bastante. Es muy difícil que se queden tranquilos, lloran mucho, al llorar mucho tienen mayor probabilidad de hacer aspiraciones, así que sí, de primera intención, videofluoroscopía, y en esta época de COVID, más todavía.
Muchas gracias, Hugo.
Perfecto. Entonces, vamos ahora a hacer una segunda pregunta.
Álvaro, solo hay una poll.
Sí, voy.
Clef. Solo
voy.
hay una poll de...
Sí.
Ok.
Bueno, preguntas desde el chat, Álvaro, por favor.
Espérame un poquito, Patito, que tengo solo una pantalla. No tengo cómo ver las preguntas.
Ok.
Solamente hay una pregunta del poll, Dianita, perdón, no te había entendido. Ok, perfecto, no importa. Esto es para el panel. Si nosotros nos encontramos con que hay aspiración en la videofluoroscopía, ¿todos intentarían un tratamiento conservador antes de hacer cirugía? Antes de ir al quirófano con el paciente, algunos intentan inyectar material reabsorbible en la laringe posterior, en la comisura posterior, para mejorar el espacio intraritenoideo, o derechamente hacen una cirugía, digamos, sutura endoscópica. Me gustaría escuchar la opinión de doctor Rabar.
So, Patricio, if I may just say one word about the swallow. If I can.
Yes. Sí.
Can you hear me okay?
Yes, we can hear you okay.
I would do both, but my preference is, again, a swallow study. Fees only gives me, at least in my hand, it's a little bit hard with fees to understand the physiology of the palate, tongue, and the pharynx, which is critical to understand the whole dynamic of the severity of the aspiration. So the swallow study in some ways is advantageous because it can gives you the whole swallowing pathway from the oral cavity all the way down to the pharynx. So that's one point I should make. With regard to what to do, at least in my hand, I will only use injection for two groups of patients. One are the patients who have cardiac physiology, that you have to wake them up quickly and it is difficult or dangerous to suspend them. Or patients such as Down syndrome patients who have a very unstable neck that you cannot suspend. And in those two categories, I think injection is okay. In my hand, if I am able to fix it, I would prefer to do the suture technique to close it permanently as opposed to injection. But that's a preference with me. I know some colleagues like to inject a lot of the clefts.
Mike, any comments?
I think Reza and I are kind of on the same page again here. It's, from my point of view, if I do an injection and it doesn't work, I'm going to think I better repair the cleft. If I do an injection and it does work but then wears out, I'm going to think I better repair the cleft. So I tend to find I just put in a stitch or two, and we're doing a mass closure technique. It's not very sophisticated. It's simple and fast, and it's really our first year fellows do them, and so it's simple enough that our threshold for doing something that is unlikely to cause harm is lower than it used to be. So I personally don't do injections, and I say this, two of my colleagues do. And it's not that one is right or wrong. It's just, in my hands, like Reza, I prefer to put in a stitch or two. I'm very comfortable doing that.
Thank you. Dr. Trozzi, okay. How do you do that in Rome? Last opinion.
Yeah, I agree with Mike about that, because we don't have much experience with the injectors of bubble material. We used to do that. So we go straight for symptomatics. Of course, a patient, we go straight with an endoscopic suture. But it happens quite often to see a deep notch that is completely asymptomatic. So we call an occasionally diagnosis. We ask for a video fluoroscopy. If it's negative, if the clinically is negative, we prefer conservative treatment.
Thank you very much.
Okay. Bueno, Álvaro, por favor apagar el audio de las personas que he estado habilitando. Por favor, apagar el audio. Álvaro, podemos continuar con unas preguntas.
¿El chat?
Desde el chat, por favor.
Ok, estamos en eso. A ver, en el chat no hay muchas preguntas, hay muchas opiniones sobre cómo mejorar el video y
¿Alguno de los que está en este momento en pantalla quiere opinar algo? ¿Algún comentario, algún saludo? Jaime Patricio Beliá. Te escuchamos, Álvaro Pacheco, si hay algo después.
Sí, sí, sí.
Patricio Beliá.
Sí, quería hacer un comentario con respecto a lo que hablaron sobre FES y videodeglución. Creo que estoy de acuerdo con Reza, nosotros hacemos videodeglución antes de hacer FES porque nos da una mejor relación entre la fase oral y la fase faringolaringea, que el FES no nos permite esa relación entre el primer tiempo de glutorio y el segundo tiempo. Creo que esa es la ventaja que tiene la videodeglución con respecto al FES. Y con respecto al tratamiento del DIP y el paciente sintomático, nosotros siempre primero hacemos tratamiento fonobiológico de la deglución antes de un tratamiento intervencionista. Tenemos algunos buenos resultados con los tratamientos fonobiológicos y mejoran bastante y dejan de aspirar los pacientes, fundamentalmente con el crecimiento.
¿Preguntas, Álvaro?
Sí, estamos en eso. A ver.
Ok, Alvarito, yo había visto una pregunta de un neumólogo que pregunta qué papel tienen ellos en,
esa era la
como en
pregunta.
el diagnóstico endoscópico de estas patologías o qué papel tiene la broncoscopia flexible.
En realidad, la pregunta yo creo que va un poquito dirigida a lo que es el centro aerodigestivo, en el fondo. A algo más interdisciplinar.
Sí, Mike, ¿qué opinas?
Tráquea, etcétera, etcétera.
Reza.
The role of the aerodigestor center. I think that a lot of these children have multifactorial problems, and I think that we provide better care to an individual child as a team than as a group of individuals. And that's pretty much it in a nutshell.
Gracias, Mike. Bueno, hemos avanzado en nuestro webinar. Reza, creo que por tiempo nuestra conversatorio de COVID lo vamos a poder desarrollar en otra oportunidad. Infinitamente agradecida por que han compartido este espacio con nosotros. Han dado de su tiempo, de su generosidad por compartir el conocimiento.
Nos gustaría ver los videos encendidos, quizás, Diana, ¿están autorizados?
Estoy tratando.
Pero ya están conectados.
Sí. Cada uno creo que tiene la opción de encender su video.
Todos tienen la opción de encender el vídeo. Si alguno quiere saludar o hacer algún comentario. Ahí vemos a José Rafael Gutiérrez. Se atrevió. Entonces, Diana, después le damos la palabra a nuestros panelistas para que se puedan despedir, quizás.
Sí.
Sí. ¿Puedo,
Thank you very much for the invitation to be part of this, and it was great to see a lot of old friends. Be safe out there. Thank you very much to everyone who organized this.
Yo también quiero agradecerles la invitación, quiero felicitarlos por el esfuerzo que esto fue y por lo que dijo Mike, ver tantos amigos en la pantalla y una cosita aparte con respecto a Reza y el COVID, que desgraciadamente no lo pudo comentar, pero él ha hecho un trabajo maravilloso, ha hecho 3 comunicaciones de todo un grupo internacional de otorrino pediátrico, donde cada uno expresó sus necesidades, sus faltas de insumos, y en el último fue todo lo que optimistamente uno podía esperar en las próximas temporadas post pandemia. Así que una felicitación a Reza también por ese trabajo que ha hecho. Y a ustedes, congratulaciones.
Me vuelven a llamar, pero no me dijo de parte de aquí.
Todos pueden activar sus pantallas si lo desean.
Nadie quiere.
I'd like to just second the thank you to Diana and Pato for getting this arranged. This has been absolutely fabulous. Considering the challenges that you've faced, getting society to change from traveling someplace to meet in a room to staying where we are, getting pulled at by the operating room, still Zooming together so we all work together and share information. Amazing. You guys have done a great job. And thank you to all the panelists for being friendly and open, sharing their ideas.
Well,
This is Cincinnati saying goodbye.
Gracias. Nos vemos en julio.
Gracias, Mike. Gracias, Sandro. Gracias, Catherine. Muchas gracias.
Patricia, I want
Gracias a todos por compartir. Les deseo lo mejor. Cuídense mucho.
May I also say a thank you to Diana and Patricio for organizing this, for Diego, for your kind words. I think the benefit of the technology has really served us well, and thank you for the whole organization. It's impressive that we still have close to 500 people connected. So a big congratulations to all of you.
Thank you. I want to join the congratulations and special thanks because you think about me to join this amazing panel. Thank you very much for the opportunity.
Con gusto, Marilena.
Gastón, Jaime Penchina.
Bueno, yo repetir el agradecimiento y mis felicitaciones. Es increíble cómo ha salido y es aún más sorprendente que a esta hora haya 455 personas conectadas. Así que esto me hace pensar en dos cosas. Una, que ha salido increíble porque si no se escucha, no se traduce bien, no se ven bien los videos, la gente se hubiera ido. Así que eso creo que hay tanta gente porque se ha visto y se ha escuchado de una manera increíble. Y segundo, que creo que es de gran interés, por eso hay tanta gente. Y hay muchos temas que faltan tocar. Así que dándole un poco de publicidad, para el
siguiente
3 de julio. 3 de julio, creo que va a haber muchos temas interesantes que han quedado en el tintero, así que esperemos poder aprovechar, si Dios quiere, de un nuevo webinar con gente tan prestigiosa y con tantos participantes. Así que mis respetos, mi agradecimiento y mis felicitaciones a ustedes.
Gracias.
Gracias, Jaime Penchina.
Muchas gracias, Pato y Diana. Excelente.
Melissa.
Thank you all for wonderful lectures. And congratulations, Pato and Diana. Wonderful, wonderful.
Jaime. Gracias, Melissa.
Quiero agradecer la invitación y felicitarlos, Pato y Diana. Esto es increíble. Tendremos que hacer más cursos como este, meetings, haber visto a todos los amigos, Reza, Michael, todos. Una sincera felicitación, Pato y Diana. Salió excelente, me encantó. Muchas gracias.
Ok. Alejandro Coxaglia. Hola, Eduardo. ¿Cómo están? Gracias, Pato Varela, por apoyar siempre las ideas crazy que surgen. Nada, esto es una pasión. Me encanta verlos. Eduardo, Michele, Melissa, José, Colombia, Alejandro. No sé, ¿qué más quieren
Diana, Michele Torre está con
Michele,
micrófono.
no te veo.
Y después Michele Ugasi, que está escondido por ahí.
Ok.
En ese
Michele Torre.
Muchas gracias, Pato, Diana, y a todos. Ha sido un placer verlos, aunque solo virtualmente. Qué lástima que no podemos ir a celebrar juntos y bailar y cantar y tomar, pero lo haremos otra vez. Y qué bueno que haya estado tanta gente y de muchas especialidades. Y esto de verdad en el espíritu de Impact. Así que creo que esto siempre sirve, estar juntos y compartir con muchas especialidades. Así que ojalá se pueda seguir con Impact Chile. Y bueno, estamos en contacto. Gracias.
Ugasi.
Hola, muy buenas. Increíble la tecnología. Estaba en la casa y ahora estoy en quirófano y he estado siguiéndoles todo el tiempo. Excelente la transmisión, Patricio, Dianita, Álvaro, un equipo, y por atrás también anda Eduardo y otros más. Gracias a todos los colegas y amigos de este gran Airway World Family. Comenzamos hace algunos años en Quito, ahora somos 250 y más, y ahora han habido como 1000 extra colegas que están apasionados por esta gran especialidad que es la vía aérea. Una vez más, un abrazo a todos. Esperamos en julio tener algunos casos, Pato, para presentarlos. Chao con todos.
Chao, Miquelito, gracias.
Grande, Miquele.
¿Alguien más quiere comentar?
Gracias, Marilena, por acompañarnos, por tu entusiasmo, por tu excelente presentación y comentarios. Nos vemos muy pronto.
Gracias a los asistentes de todo el mundo por confiar en la organización de este webinar. El reto es poder integrarnos y poder tener en el futuro, compartir las experiencias con ellos, que hacen ellos, sus publicaciones, sus preguntas, sus casos clínicos. Así que esto solo tiene un rumbo y es crecer.
Saludos a todos. Excelente webinar. Los queremos.
Antes de despedirnos, Diana, también agradecer a nuestras brillantes traductoras. Silvana, Claudia, muchas gracias por acompañarnos, no solamente hoy día, sino en toda esta preparación del evento. Hicimos algunas pruebas antes, era un riesgo, era un desafío. Es una licencia de Zoom más compleja, con webinar, con traducción, y estamos muy contentos de que haya resultado bien y que ustedes hayan disfrutado. Dejo a Diana y cerramos.
Hola, Sarita, que te veo acá. Bueno, entonces les dejo.
Chao, chicos.
Con mi lindo video.
Hasta la próxima, es muy lindo todo.
Hasta el próximo mes.
Chao, chao.
Increíble todo.
Bueno, tenemos que quedarnos, Diana, Álvaro, Pato, hasta que
se vayan todos.
Porque todavía quedan 274, 273. No podemos abandonar el barco todavía.
No. Tendríamos que descorchar un vinito, algo, no sé.
Eso.
Claro.
Puedo aprovechar, nada, para felicitarlos. Realmente creo que se han cumplido las expectativas que teníamos con respecto al webinar. Y nada, hablar de lo que suelo hablar yo siempre, que esto es la gran familia de la vía aérea que empezó, como dijo Michele, allá atrás en el 2013, y que Diana creó ese chat de WhatsApp que ya no existe porque estamos en Telegram, porque hemos superado la cantidad de participantes en el 2014, y la convocatoria sigue. Hoy tuvimos casi cerca de 1000 participantes con los mejores especialistas de la vía aérea del mundo. Nada, seguimos adelante, seguimos aprendiendo. Siempre hay tips en todo lo que hacemos. Les marco uno, por lo menos para mí, que la primera vez que lo escuché, el tratamiento del club de Mike me pareció algo muy llamativo. Siempre, en todas las reuniones que hacemos, hay alguna cosa nueva que aparece y que hace que esto valga la pena, como lo venimos haciendo hace tantos años. Así que felicitaciones a todos y nos veremos en julio, obviamente. Lástima que no podemos salir a comer, a bailar, igual. Pero ya va a volver. No lo reemplaza, esto no reemplaza que nos podamos juntar personalmente, pero es un buen método.
Tenemos una inquietud de nuestros asistentes. La asistencia está certificada por la Clínica Chayo. En estos futuros días estarán recibiendo su certificado online.
Bueno, Diana, tú tienes que cerrar la casa hoy día. Nosotros nos vamos a ir, te vamos a dejar con los asistentes. Hay 200 conectados todavía. ¿Qué hacemos?
220.
Le pedimos a...
Llamemos a Reza que dé la charla de COVID.
Al doctor Ugasi que haga alguna conferencia de algún tema.
Que se cuente un chistecito, doctor Ugasi.
Bueno.
Yo lamento que no puedan abrir las cámaras los que están presentes. Veo
pero sí, la han ido abriendo.
Aldri Wesh, Verónica Rodríguez, Lorena Núñez, nuestra querida Cecilia Borel.
Yo le he pedido a la doctora Borel que abra su cámara varias veces, sino que ella. Ahí está.
Fundadora de la unidad.
Pero, Verónica, hola Vero.
Chicos, los felicito, pero estoy manejando hacia eso no quería hablar porque es un poquito peligroso, pero los felicito por el esfuerzo y genial el meeting, me encantó.
Gracias, Verito.
Lucía, que la veo en cámara, no quiere hablar, prenda su micrófono.
No, nada más decirle felicitaciones, que fue increíble el meeting, así que muchas gracias por todas las charlas.
Gracias.
Y bueno.
Bueno, entonces
cerramos.
Yo creo que hemos llegado al final.
Gracias, Diana, gracias, Álvaro, gracias, Pato, gracias a todos.
Gracias, gracias.
Muchas gracias.
Bueno, hasta la próxima.
Un abrazo a todos. Chao, chao.
Chao, chao.
Mil gracias a todos, muy amables. Excelente.